inspection in 2024 and 2025, on page 26, they compare the 2 years and there wasn't much improvement. Since the, 7, 8 months since the April, have things come along and improved? We all know we're in winter and there's always winter pressures, which should be planned for because winter happens every year, but we do all understand there are more pressures. And can I ask, without corridor care, when you have those pressures, would the alternative be to turn the people away? Yeah, I'm just asking what the alternatives possibly could be. Thank you.
Mike, oh, there it is. Yes, some of the changes.
Yvonne, can I just ask you to turn your microphone off? Is it off or is it on? I can't
It's
see.
on now.
Yes.
Sorry. Just to say, so some of the big changes we've made in the department is around staffing. So we've recruited a number of nurses and doctors. We've changed the skill mix within there, making sure we've got really good medical cover. So there are some of the big changes that we made down there. And sorry, your second question was around.
Well, corridor care, what would the alternative be?
So there is no alternative. We don't turn anybody away, and we bear the risk. So if I look back 3 to 4 years ago, patients were waiting in the back of ambulances and ambulances were not getting back out on the road. So the decision we made at the time and across a number of hospitals is throughout the NHS is that the hospital would bear the risk, because in that way the patient gets seen, gets assessed, and we can start to initiate care and get those ambulances back out on the road, and indeed not have anybody sitting in our forecourt in the back of an ambulance.
Okay, thank you.
Councillor Printer. Just turn your microphone off, please, Councillor Wiley.
Okay, thank you. Yeah, just reading through the report, it's got the chart there with the colours. On both years, you've got that it's being well led, but everything else is below that. So it seems odd that if it's being well led, but patients are not safe 1 year, and the other markers come low. Can you tell me how that's happened? I attended the emergency department for my daughter's had an injury for playing sport, and it seemed we was almost mixed in. I know you get triage and you get sent to different places, but we were still waiting with other people who had more of an immediate need. It just seems there needs to be a different system for that. I mean, I didn't mind giving up my Sunday night and waiting to be seen, and the care was great, and it got looked at, and no, that's not for us, you need to go to East Grinstead. But it seems there needs to be a different way of getting to that point and out of that department. So I don't know if there's any initiative coming up in the future to separate a flesh wound, a mere flesh wound, to those who need that immediate more care, are waiting around for a long time. And just touching on, you've mentioned the virtual ward. We did, as a family, make use of this as the smart team, and it was fantastic. It was really good that we weren't in a ward. It cleared that ward, and I'm pleased to see that it has been expanded. How do you make sure, because we still had to give a lot of support, because the nurses are not there all the time, of doing the readings, inputting them into the equipment, etc. How do you ensure that through the rush of clearing beds or not moving people into the beds, that we ensure the people the right setting and the support are put into that system? But I'm pleased to see in the report that you're expanding it even more. I mean, 200. I mean, I don't know how many wards that potentially is replacing. So thank you.
So I'll deal with the well-led question first. So yeah, we have got good for well-led, and that's a real testament to the team within the ED department, and that's around them showing that good, compassionate leadership within the area. Sometimes, despite that, the conditions within the area will not be what we want them to be, but on the whole, that's what they found in relation to that. So it's around developing our staff, making sure our staff were appropriately trained, making sure that we're getting regular appraisals, looking after their well-being, etc., making sure the right policies and procedures are in place, making sure that we're raising any safety concerns, that any incidents are being reflected properly and appropriately. And secondly, around our virtual, we'll absolutely take that on board. The development in the virtual ward, we call it now the virtual hospital, because what we've implemented is 24/7 remote monitoring. And we've just could have really escalated it over Christmas and New Year. But what we wanted to do was take it very slowly, very carefully, making sure we've got the right skill mix of staff, that monitoring is absolutely doing what we wanted to do, that we've got really good clinical oversight in there. That's why I'm saying we're hoping to bring it up in February, but it'll be done safely and slowly so we don't have to stand back from it.
Yeah, and is there any other initiatives of moving people not going to ED? And as well, if I can come back, what's the cost of a virtual ward versus an actual ward? Is it the same? Is it a lot more? You know, is that something you can answer? I'm not sure.
So first, I'll go back to the initiatives first, just in case I forget that one again. And yes, there are initiatives. So the divisional team and the team within ED are looking to how we can change the front door. So absolutely, that streaming when you come in, who is the right person for you to see? Is it a doctor? Is it a nurse? Is it a pharmacist? Is it a therapist? Indeed, is it a different tertiary referral centre like East Grinstead or somewhere like that? So we're trying to work on that. Now is not the right time to do that, but the initiative is once we've freed up space within our ED, we're going to be able to do that and use our front door more effectively, because you're right, everybody's coming in through one front door and that's not the right way it should be. So it should be ambulance come in, you know, those critically and seriously ill patients, and then we're able to stream our other patients to be more appropriately and get sent to the right place. Plus it's a better experience for especially certainly young children. And cost, I'm not going to be able to give you that right now, but it certainly would be, I won't say cheaper, it's going to be different. I think there's a misnomer that delivering care in the community is cheaper. It's not cheaper, but it is, it can be more effective and a much better experience for our patients. And the other risks that are reduced are, you know, hospital-acquired infections, you know, our patients becoming deconditioned within hospitals while they're lying in bed, not getting up and about. Whereas if you're moving about in your own home, no matter how small, even if you're furniture walking, that is much better. You're getting a better night's sleep in your own bed, but you're getting those interventions that you need. Those staff still have to be highly skilled. The remote monitoring does cost, but what you might be able to reduce are the other costs within the hospital that you might not bear. But more importantly, you free up the right beds so that you get patients into the right specialty bed, not just a bed.
Thank you, Councillor Printer. Councillor Cook.
Yeah, thank you. I mean, a lot of what I was about to ask, you've just covered with Councillor Prenter. I think the other bit of that for me was the safeguarding and the wider costs and benefits around physically going into someone's home and seeing any wider needs, but also the kind of opportunity loss, so to speak, of the wider social care problems of somebody being in a hospital and loneliness and isolation. And I was just going to ask a little bit more around that in terms of the costs. Thank you.
I don't think I can add anything any more than what Siobhan said with regards to the cost, but one of the things that we are doing is emphasising on discharge. There's a lot of, there's an initiative we started around safer discharge, and we're working with social services, our community partners, about making sure we pull people through the system. Where there's a big emphasis on people coming to ED, actually you've got the back door, so we have to make sure people are discharged safely, because as Siobhan just sort of mentioned, the longer people stay in hospital, they do become deconditioned, and actually it is not the right place for them when they're getting better, and sometimes they can pick up an infection which ends up extending their length of stay. So that piece around doing safer discharge alongside with various partners is something we're emphasising on as well and have started.
Thank you, Councillor Cook. Councillor Hamadishi.
Thank you for the report, and I'm glad that we're moving slowly in the right direction, but pace is going to be the central theme of my questioning, really. NHS England rolled out virtual wards in 2022. There's something to be said about most NHS trusts, and you can pitch in if this is applicable to Medway, in the sense that we don't share information with other trusts in a timely way. So I take on board that you take safely and slowly, but the residents of Medway needs good, effective care now. Most clinicians will tell you, and patients will tell you through their surveys, they were told that nighttime is the worst time. Being admitted in the night is the worst time. So we've known this as a truth for a very, very long time. So my question to you is, why has it taken so long to extend the hours? You did mention that you got the staffing involved. How well are you making sense of the data that you're receiving that gives you these alarm bells that, look, we're breaching poor care and all of that stuff's happening? And again, how are we learning from other NHS trusts as it relates to virtual wards? Thank you.
So I probably didn't make myself clear. So the virtual ward has been at Medway for a considerable number of years, but it's not been 24/7. And that's very similar to other trusts across the country. So our initiative here is 24/7. So what was happening before with people who required antibiotics during the day, we would go out during the day, do those, but there was no interventions required at night. So it was almost patients who were really close to discharge that we were kind of managing within our virtual ward concept. We've taken that one step further, and we've gone for patients who do require monitoring, and we are taking them out, and we're looking at that. It's too early to bring any trends about what we're finding, but what we have found is that when patients do deteriorate at home, our systems are working in terms of the escalation is working, and we're able to fast track those patients back into the hospital for a further intervention. It may just be for a further intervention and then go back out, but for some we have readmitted, but I don't have those stats at the moment because we're still in early days yet. And that's why we want to make sure our governance process are right. Are our systems working? Because this innovation of 24/7 is new, and this remote monitoring for patients who would normally stay in hospital. You find remote monitoring for patients who are stable and discharged from hospital. These patients aren't discharged, they're still within our care, but we're delivering the care in their homes. So I'd love to be able to bring back to you in a few months' time an update on the virtual hospital with our outcomes and hopefully relay some of our patient experiences as well.
Councillor Shocker.
Thank you, Chair. So my question, I've got three questions. So what specific actions are being taken to address the overcrowding and long waits in the emergency department beyond expanding the virtual ward? Would you be able to give specific examples how you're looking to increase the community capacity? Also, there's a question regarding virtual wards. There are criticisms of them, with some sources citing it potentially to worsen health out inequalities. There's burden on informal carers, and there's a concern that they are just a stopgap rather than a systemic solution. Will you be looking to provide specific evidence for outcomes in Medway to address these criticisms? Examples being like an assessment on the impact and strain on family members.
Okay, I think we raise a really good point there around carers and family members. All of our patients have to consent to go out with our patient, with our hospital at home virtual hospital team. But that certainly we will absolutely consider is looking at the carers. We're already doing it with our patients, but I think the wider family is a really good initiative. So we are not just depending on the virtual ward. We are working really closely with our system partners. So the Community Trust, with the Mental Health Trust, with Kent Social Services, Medway. We're working with private providers, and we're also working with our charities to make sure that we are more joined up and we stop patient needing to come to the front door of the hospital so they're able to access those services. So a big part of our initiative for the next year is working within the system about this left shift you've heard about us working much more closely out in our community, really looking at primary care, intermediate care, and then if it needs to escalate, what does that look like? We certainly need to look at our frailty model. We need a really cohesive, joined up approach to our frailty. That's the majority of our patients. If you were to come into our ED department, you would see the majority of those patients fall into that category. And so we really need to be providing a more comprehensive service for them within our community, joined up with the hospital. It doesn't need to be delivered all within the hospital. Most of that care can be delivered joined up wise at primary care and at intermediate care level. And we're working with system partners to do that. It's quite an exciting project, we think, this year. And it would be great because what we need to show is a reduction of these vulnerable patients attending our ED department, but being able to access their care at home and that their families and carers get that support as well to enable that to happen.
Thank you, Councillor Shocker. Councillor Jackson.
Thank you.
Sorry, Councillor Jackson. I did forget Jackie. Did you want to just mention one thing on Councillor Shocker's question?
Thank you. Yeah, I just wanted to comment on this. We are working very closely together. We're working, there's a programme called the Better Care Fund Support Programme where we're getting support from the LGA and Newton around how can we work more closely as system partners, not only to support people to be discharged from hospital, but also to prevent people being admitted. So it's a really working closely. But what I wanted to sort of mention was actually from an adult social care perspective, we're doing a whole piece of work at the moment about reviewing the carers offer in Medway. So we're at a place now that we will then, we're starting the paper to go through governance, and we need to consider whether that needs to come here, but definitely taking that to our partners to look at how we can work together on that.
Thank you, Jackie. Councillor Jackson, the floor is yours.
That's okay. Some of the questions have already been answered, but working in A&E and working for the ambulance service in the past, sometimes we can talk about these bigger issues, but sometimes like on the day it can be like the little ones that just mount up. So one of the ones, yes, discharges where we've got patients waiting for care homes, but on the day and the weekend, sometimes it can be patients waiting patiently to be discharged, but they're waiting for their medication and everything, and that might only be their discharge delayed by 8 hours. But if you've got lots of patients being delayed by 8 hours, so and that's a daily thing. And obviously at the weekend, sometimes it can be, you won't be discharged till the Monday when someone's back. And also being in with frail patients that are brought to hospital by ambulance and then they've had their treatment, it's actually getting them back home again that will take up a cubicle while you're either waiting for an ambulance or and again, it might only be an extra 4 hours, but them extra 4 hours soon add up when you've got lots of patients coming through the door. And also, just for something I was quite interested in, as the ambulance, you no longer sit on the ambulance. I just wondered, there used to be this old myth that if you called an ambulance to go to casualty, or A&E, that's how old I am, casualty, that you would get seen quicker. I'm wondering whether the ambulance turnaround time and then the patients waiting in A&E with everybody else, that there is reduced the number of people calling an ambulance. You might not be able to answer. That was just, if you knew, it would be nice for me to know. Thank you.
I guess you sort of, a few things you've talked about there. There's something around patients waiting for medication. We've got pharmacy technicians that are there 24/7. So to try and reduce the length of time that people are waiting in order to receive medication for them to go home, because it is in our interest and in the interest of the other patients for those patients to go to leave ED. We've also got discharge doctors as well and discharge nurses, and you've also got the site team where they ensure that people are discharged quite quickly. So it's not just a 9 to 5 service, it's actually a 24/7 service, including the weekend. And in the past, I've been in a lot of those meetings, making sure the conversation is around what are people waiting for and what else do they need to help on block for them to go home. You talked about frailty specialist team, which we also have, and they're able to go in and in-reach into ED. So it's not just about the ED team, they're consultants, specialist nurses that in-reach into ED to try and pull people out. Ambulance turnaround, I don't have that specific data for you, but I do understand the myth that you're talking about where people feel that if they call an ambulance, they get seen quicker. Everybody is triaged in order to make sure that they get the right level of care that's required.
So, can I just come back? So, I understand about it, but people, because people are still waiting a long time just to be I'm not talking like long time, like weeks. I'm like talking about hours, but them hours do add up.
Absolutely agree with you. So we had a MAID event. So a MAID event is a multi-agency discharge event, which Jackie will be aware of because her team are really involved in that. And it gives us an opportunity to look at all the blockers there are to discharge. So what are, so, you know, we on the board round in the morning, the team will be in the office and go through every single patient and go, what's happening with them, and ask, are the TTOs, so the drugs, are they written up? Has it gone to pharmacy, you know, the EDN, etc. And so we have found some blocks in our own system as to why that's not happening quickly enough. So you're absolutely right. And, you know, those couple of hours for every patient, you know, we discharged 83 patients yesterday. If all of those were delayed by 2 hours, that's, you know, a huge number of hours of beds that we could have prevented people being blocked in ED. So absolutely do own that one. We are working on it. It's not a quick win and it's not an easy one. And having worked in the Dartford system as well and in the Maidstone Tunbridge Wells system, I'm not sure we've all cracked it. We need all of our digital systems to be talking to each other, which is another issue for us. But absolutely, certainly that's one thing that is a common theme. So thank you.
Thank you.
Thank you very much. Leanne from Healthwatch.
Hello. Yes, I'm from Healthwatch. We come to Medway Hospital and do engagement with your patients on a monthly basis, and we hear about experiences in the emergency department quite frequently. We hear a lot about waiting times, corridor care, communication, things like that.
Leanne, could you speak into the microphone? Could you pull it forward to you, please?
Sorry.
Thank you.
Did you hear all of that? So I'm just wondering, with all of that patient feedback, have you used external patient feedback, but as well as internal patient feedback, and how have you used that to improve the situation in the emergency department? And is there a plan to keep on using patient feedback and all of that external and internal data moving forward?
You're right. We do use patient feedback. So we've got our friends and family test survey, which every patient is given on discharge. And people have been really helpful telling us what it is we did well, as well as telling us what we didn't do well. What we've done recently is look at the last 12 months data, identified themes across our complaints, the survey, our incidents, and we've stood up some improvement program and projects because consistently people are telling us about the wait, and our Chief Operating Officer has got a number of initiatives that she's doing around how we bring down our waiting time. Sometimes they've told us about communication, that we're not good at telling them, you know, the length of time they're going to be needed. So there's an improvement program that we're setting up. So patient feedback is absolutely key, and one of the things that we really rely on, and will continue to use that in order to shape the improvement initiatives that we set up.
Oh, that's really good. Thank you. Just to let you know as well, I know you said about the virtual ward, and it's going to take some time to see how that's improving the experience for patients. Just to let you know that we're already starting to hear feedback about virtual ward, and it's been positive so far. So I think it'd be really good to work as a Healthwatch and with the hospital to triangulate that data. But it's really good to hear. Thank you.
Thank you.
Yvonne, just going back on that question, just for a point, are you confirming that you listen to Healthwatch's feedback or just your friends and family test?
Well, we listen to all feedback. Any feedback is good feedback, bad, good. We pull across absolutely everywhere, including our governors and all of the patients. So absolutely.
Councillor Perfect.
Thank you, Chair. Thank you for the report. Excuse me, sorry, I was just looking at something else. And I think it is noting, you know, within the report, a marked improvement, certainly in some of the things that you're delivering in terms of obviously that sort of, you know, innovative ways, noting that I think obviously as Councillor Hammond-Dishay has, some of this might be a little bit behind the curve, but actually, you know, trying to certainly modernise what you're doing. And I think certainly, you know, noting some of the challenges that the organisation has, I think we can certainly see from this report that, you know, that this is an area that you're definitely, you know, committed to improving, and clearly the inspectors have found that there are marked improvements, as noted in 5.1. I guess my interest is just in terms of sort of the wider sort of picture, in terms of obviously we've noted the corridor care and some of the challenges that you're having at the moment. I guess it's maybe more of a question for you, Siobhan, in terms of where you sort of see the organisation by the end of this year, in terms of the sort of strategic picture around ED, and what do you think in terms of for you would sort of mark a good year in terms of outcomes, I guess, and I'm going to write them down and then maybe come back to them in 12 months' time.
Okay, well, certainly one of the first things I'd like to see is that we have a joined up frailty model with our community partners. with primary care, because I think that will help prevent a number of patients coming to ED. We need to change our front door, and we need to be streaming our patients more appropriately through that front door. And we do have an opportunity to be able to affect that change about midway through the year. We need to be looking at what other pathways are patients. So we need to be working with primary care and again, community to see what can we deliver outside of the hospital to help reduce, first of all, the burden on the site, which is considerable, but also the burden on patients having to travel to the hospital to have interventions. We need to be maximising our CDCs, wherever they may be, and encouraging our patients to use that. So developing this kind of, working with our system, with the ICS, working to develop these kind of neighbourhood teams that we deliver health within that neighbourhood. And the only time you should come to the hospital is for that critical care intervention or for an elective procedure that cannot be delivered elsewhere. So we radically need to change our pathways, because delivering care the same way we've done for the last however many years hasn't changed, and we need to be changing it much more radically than we do, because we can't afford what we're currently doing now. So we need to be doing it more effectively and in a more productive way, and using our staff skills to the top of their level as well. So making sure that we're supporting and developing those teams, training them, whilst at the same time having that governance structure underneath, that if anything is deteriorating, that we are able to bring patients in, but that they're seen quickly and efficiently. So yeah, a number of, they're in our plans for this year. We're very keen to develop them. And I know we had a really good development day on Tuesday with our system partners, and I believe it's quite exciting what we're planning this year in terms of left shift into the community and how we all want that. You know, I'm not sitting here asking for any more money for Medway Hospital. I would like the money to be spent in the community, because that's where I think our patients are better served, and then they'll come into us when they really need to.
Thank you. Finally, Councillor Crozier.
Yeah, thank you, Chair, and thank you for the report. Can you just expand slightly on the virtual ward? It sounds an excellent idea. Are you taking mainly patients from the emergency department, or are the patients coming from other scenarios in the hospital? And if they are the emergency department, if they've arrived by ambulance presumably, and then you deem that they need to go into the virtual ward, are you sending them back in the ambulance with equipment that they can set up at home? Just how does that work?
So we take patients from all areas of the hospital. We do take patients from ED. Those numbers are small at the moment, and they are generally patients who might require a bit more, an increase in package of care, or a bit more health with mobility. They might have come in by ambulance, but we might have to get them home by hospital transport, because the ambulances aren't able to hang around for us to be able to kind of say, stay where you are, we'll just give you this. It's not as quick as that, because they need a comprehensive assessment. They need to be accepted. They need to be seen by the consultant. There needs to be a plan agreed, what that plan of care is. So predominantly the patients will come from the ward areas as well. So there'll be patients who might need to stay in hospital to have long-term antibiotics. So, you know, some of our orthopedic patients require 10 days, sometimes months of antibiotics. We can deliver those safely in their own home. Some will be waiting for tertiary referral into a London centre, and will be in our beds being monitored. We can monitor them at home safely, and then they're more relaxed. We can do complex dressings, and we can develop, you know, we've got oxygen therapy, so we can be keeping an eye on patients. We can be titrating people's medications and looking at those. So there's lots of different pathways, and we want to refine those so that we are encouraging more of our teams to be referring into our virtual hospital, so that the patients get to make that choice safely, but also our clinicians feel that the care is safe as well.
Just a quick follow-up. So is there a big increase you said there was a smart team that goes out to them when they need to be seen. There's been a big increase in numbers of people that you need to employ to do that, or how is that going?
Yes, we've been doing it incrementally. So we've gone from kind of having around 80 in our virtual ward to about 120 in our virtual hospital, and we want to get up to 200. But it takes time to train those people. So whilst we were able to upscale and use some temporary staff, some bank staff, some of our own staff, we are recruiting constantly into that. We need to be developing their skills, because you need to be competent in interventional procedures. you need to be able to recognise your deteriorating patient and what to do, etc. And just to go back to a comment made earlier about safeguarding, you know, we need to be able to, that people are able to be mindful when you're in someone's home, you can pick up other signs of other issues that are going on. So yeah, so we're making slow but steady progress, and we are taking it steady. We could have just gone big bang, but we think that would have been very high risk. So that's why we've taken it slowly. We recognise that these few weeks would be very contentious for us, so we didn't want to take a risk then. So I would envisage us ramping up in kind of the next fortnight, and looking in February to have more patients pulled directly from ED, as well as those patients coming from the inpatient wards.
So just one more quick question. Is it taking pressure off of the ED? Because presumably if they come into ED, they've got to be seen and then sent out. So it doesn't relieve a great deal of pressure there, does it all?
So before Christmas, it absolutely was, and what we were seeing as we had loads of weeks where we had no corridor care, and we had reduced the length of time the patients were waiting for bed, so we'd reduced our 12-hour trolley delays as well. And that was when they were at their maximum of 120. So we know when we go up, we'll be able to even have a better effect in ED. But at the moment, we can't go up until we've got those skilled staff. Not worried about the equipment, we've got that. But getting those skilled staff in place and making sure that the systems behind them support them to be there.
Thank you. Thank you, Chair.
Thank you, Councillor Crozier. You've got a few from me, as you'd expect, Siobhan. I suppose the first one from me is about recruitment. How many more nurses and doctors have you recruited to the department? Because that's what you're saying in the report.
To ED?
In the report on the CQC, you're telling me that you recruited more nurses and doctors within the department. Because I understood many staff had gone from the hospital. Yeah, so how many of you actually newly recruited nurses and doctors within the department?
I don't know, it's been considerable. We made a huge investment into our ED staffing this year. It was one of our biggest factors in our safer staffing was the ED staffing profile as well as consultants, but I don't have the figures
so
to hand.
Nurses and doctors brand new coming into within the department?
Yeah. Some of them experienced, some will be newly qualified. We recruit all our own student nurses as well, as long as they meet the criteria. Okay. So yeah, we're very lucky to have the...
Because obviously staffing is really important within that department. That's why you had the failures. So I asked for that to be added, Terry will add it as well, but I asked for that to be added as an information item to come back from you if you can. Yeah. I just want to touch on huddles. Scares the life out of me. Now, for 3 or 4 years, every time I've visited the hospital, I'm sure the spokes has as well, we were sold this idea that the huddles in Medway Hospital were amazing, fantastic, achieve everything. And look at the last 3 years. It hasn't. And then we were told that the huddles were starting, and I was relieved. I think you might remember, Siobhan, I said to you, the worst thing you can have is when I used to come and visit the hospital, well, I do visit, when I visit all them, instead of being walked around the departments, I was walked around the wonderful objectives around around that office space about all your huddles. The huddles are not working, are they? Because, I mean, what are you doing different to a huddle to what we would, in our time, even the council would have team groupings or pre-shift? What are these huddles doing to ensure that you're gonna achieve your CQC outcomes? Because they're not, are they? They're not being achieved. Rather than everyone just, all huddling around the notice board, what's being done differently, Yvonne?
So the emphasis is not about the data. So first thing in the morning, people do get together and huddle and talk about what the shift has been like from a handover perspective, what to expect going forward, looking at, based on the day before or the last few weeks, potentially what could be coming through the door, giving people the opportunity to talk about what help and support they need. So I guess previous huddles seem to have focused on the data. The huddles now are giving people the opportunity to talk freely, what they're frustrated about, what it is they need help. It's a touch point as well for individuals, how they're feeling, because in ED it can get quite busy and people are able to say, I'm having a bit of a bad moment and I need some support. So what you were shown around is focused on sort of the strategy, the data, The ED huddles are very different. It's a different type of conversation that's needed. It's done with, from the matron to the head of nursing to the doctors, everybody talking about what could come through the door, what support they need, what equipments they need, what they need to escalate. It's a very completely different type of huddle. And that's the difference in what's working.
So I won't push you on it, Yvonne, but so basically what you've done is brought back the old model, and that's talk about the people on the ward. Because all it was for 3.5 years or more was talk about your data and your targets and your outputs, when really all the teams that I've known, anyone that's worked in the healthcare service would know, when you go into a shift, you always talk about what you got, who's signposting, how many people go in. That's that's normal hospital practice, right? So that's the difference. You've gone back to the correct model rather than talking about outputs and outcomes. That's good. Can I just ask you, look, I'm going to be honest here, you know, we're now doing checks on the food and making sure people are being fed right and the toileting and people not being put in pads. Why did it go wrong? How in this day and age in a hospital can we have people being put in pads, not being fed? How did it go wrong in Medway Hospital? I'm not worried about the rest of the country. How could that go wrong when you've got individuals, like people in there that need that help and support, and we couldn't even do that basic safe practice? Why? Why did it go wrong?
As a nurse, there is no excuse. There's absolutely no excuse for that lack of basic care. You don't even need to be a qualified nurse to be able to take somebody to the toilet. I don't know why it happened. It's unforgivable, and we need to make sure that it doesn't happen. And that is about us keeping an eye on the staff, making sure they're supported. You know, did staff feel that no one was listening? They were working under tremendous pressure. It was really tough. Were people listening to their concerns? You know, certainly staff are able to tell us, you know, it's really tough. I need this equipment. We can do something around that. There's a lack of pillows. We can get pillows. You know, if they're raising their concerns and those concerns aren't being heard, then maybe staff do think like that. I can never envisage a day like that at work. I would have to leave if I felt like that. So it is unforgivable, and we need to call it out and say it's not to be tolerated. But we also need to look and see, as an organisation, were we listening? Were we hearing? Were we doing all we could, or were we just looking at the facts and the figures? And so it is that focus, and that's why I really welcome Health Watch, because actually they tell us how it is, and we have to be listening to that from all angles.
I mean, you're right, and Health Watch hears that, and I can tell you nearly every councillor around this table would hear that from their residents, or get emails, or be told that people are waiting hours, and, you know, I suppose that's a different thing, but I do appreciate your honesty, Siobhan, and you are right. I suppose the thing that I think about, whether they're a nurse or not, they're human beings, your staff. Why would you let another human being be treated like that? But from what you're telling us, you're confident that's not happening anymore. Your breach of 2 regulations, when you're coming out, because you've got other things on your agenda, haven't you, from a governance point of view? I'm going to call it merging, but you're coming together with another hospital. You've got all these other things going on. Safe, keeping your care and your patients safe should be number one priority, not all the other stuff, surely. So what's your plan? I think I'm touching on what Councillor Perfect and Crozier was saying, and others. On your action plan, when you're coming out of these, when you're going to all be great on these 2 breaches? When's it all going to be wonderful?
Well, I wish I had that telescope to tell me when. It's something, it might sound quite trite, but it's something we should be striving for every day, is to come out. What I say to staff and to teams is, it doesn't matter when CQC come in. We have CQC in the building every day. They're called the public. They're in the building, they're in our beds, they're experiencing our services. And really, that's who we're meant to be getting it right for, not the CQC. So when our patients start to tell us, actually, we had a good experience, actually, we got good compassionate care, that's what we need to be listening to. That's why it's important what Yvonne said, you know, all feedback is important. And so, I don't know, we might call it Fort Bridge. I don't know if we'll ever get there where it'll be perfect, but we need to be striving for that every day, so that it's the right care in the right place, given by the right skills, and get our patients to their best bed, which may be home, or it may be in a hospital.
But there's no target, there's no
There will be a
executive,
target.
there's
There will-
no exec, I mean, from an executive, you must be saying to yourself, let's get out of this in 6 months, 3 months, 9
Absolutely.
months. You must have a target, surely.
Absolutely, and that will be in the action plan. But I think we have to recognise that we need to be developing outside as well to affect what's going on inside. But yes.
Can you just tell me, I've only got a couple more for you, be glad to know. Can you just tell me how dignity and privacy is protected then, considering what I've mentioned about your breaches and the things that went wrong? How is your dignity and privacy protected during surges, i.e. when you're shoving people in corridors and others? How are you ensuring that dignity and privacy is fully protected for every resident that goes in through your doors?
So there are a number of things there that we do. Firstly, there's looking at the type of patients that go onto the corridor. We always make sure we've got extra staff in, so there are people that we call them roaming care support workers. They're there, present, identifying when somebody needs toileting needs. We also have, and those runners also tend to make sure people have blankets, pillows, and actually just having a blanket to make sure somebody's dignity is covered is really, really key. And that's something that runner tends to do quite a lot of. Where there's toileting needs, we do have rooms that we're able to take patients to ensure their privacy and dignity is maintained while that toileting need is being met. We also have family members that sometimes accompany individuals. We do have those conversations with them to say, you know, this is not the ideal place for your loved one. I wouldn't want my loved one there. But actually, should your family member need anything, do flag to the runner. We've got call bells. And those call bells alert us to patient telling us what some of their needs are. One of the things that was also talked about was being able to have those confidential conversations. Again, privacy. There are the same room is sort of we take individuals there to be able to have conversations with their loved ones, so it's not within earshot. So there are a number of things that we have put in place, and they're live, and we've got a sort of a care plan, and that's done every an hour. You've got intentional rounding, and every half an hour, depending on the needs of the patient. That's something that's quite live.
So you're confident, Yvonne, that nothing ever goes wrong on a surge when you're packed out, that every single patient in your ED is being looked after and their dignity and privacy is respected? Are you at this? I'm not asking you to put yourself totally on the spot, but are you fully confident that even in this busy time, because we all know things can go wrong, we're not going to, we all know that around this table. Are you fully confident that you're there now with regards to, I'm not talking about just the policy, I'm talking about in practice, is the department right there now not failing on this dignity and privacy at all?
Sorry, I can't get the mic to work. So I'm not 100% confident, so I'm not going to sit here and say to you, oh, yes, I'm 100% confident we've got it right. What we do have in place are the right individuals, from the nurses to the matrons to the heads of nursing, that are visible. Siobhan and I go into ED ourselves. We do that walk around. So there are multiple eyes. And it's not just about the nurses doing that. It's also the family members. It's also the doctors. Should anybody see anything, they do become, I am my brother's keeper. So therefore, that camaraderie within the team really helps. And should anything go wrong, we surely hear about it.
You only have to turn Facebook on, right? Locally. I'm just going to bring Jackie in. Well, Jackie might want to comment on this one, because I do see in every time you give us a report, you tell us about discharging, and you've got people in there that needs to be discharged, but you're not getting it quite right. There's not enough places for them to put them out to. How are they being tackled at the moment, your discharge blockages? How are you tackling them between the hospital and between the team? Who wants to go first, you, Jackie, or Siobhan?
I'm happy to do this. There's been an absolute shift, I think, in the last few months. They're very much used to be apportioning blame, and that's gone. We are working much more closely together, and actually all recognising, so I'm going to change my glasses because I can't see, and all recognising actually our part in that. And I think we were doing that before, but as silos. And that's where, and I say, the shift part very much is around actually the hospital looking at what is it that they need to do internally, what does the adult social care need to do, but then how are we helping each other and how are we working with each other to do that? That's not to say that we're not still facing challenges. We have regular meetings, weekly meetings, daily meetings to talk about this and discuss this. And I was just looking at our data while we were talking this through about our numbers. And I can see that actually in the last week, the number of people that we need to support has increased, not significantly, but it has increased. And our numbers can range from somebody waiting for 90 days, for somebody being able to be discharged within 5 days. But that working together, and I said I've been doing this for 5.5 years now, and it's been the same repeat pattern, is very, very different in the last 6 months.
Thank you, Jackie. I don't suppose you want to add on anything to that, Sean. You're happy with that response? Look, I just want to finish just on the corridor care where I started. I think you know, I know pressures are on the hospital. I know it's difficult. You will see on the TV and everything else, even the health, our Secretary of State for Health is saying corridor care is not acceptable. And you'll probably have reasons that, you know, you'll probably say, but that's fine if you pump money in or whatever, which I wouldn't blame you for saying. However, it isn't acceptable. I've sat in your corridor as a patient for 36 hours. I sat in your corridor. I sat on a bed in your corridor. I didn't see any. This was not since you've been there, Sean, but it's not a nice place to be. And I helped 2 or 3 patients to the toilet and everything else, and they weren't helped at all. And I'm not the only one around this table that's experienced that. So I suppose my heart goes out to those in the corridor. It's not good enough. You know, I'm going to say that's not good enough. And I know from you've been really honest, and you as nurses nurses would definitely say that they don't want to see a patient in the corridor. You don't give good care. But I would like we will probably call you back about that corridor care at some point. And it'd be interesting to see what the ICB think about that as well. They're talking about something else this evening, but you know, I suppose the message from us is thank you for your honesty tonight. Your honesty's been really good. Thank you so much for that, and please wish Jonathan well for us. But I'm going to say that having, you know, inadequate or having not a service that's not safe is not where we want to be. It's not good for our residents. But you have some amazing staff at your hospital, and it's not good for them either to have this all the time going against them. So please take that back, that we do, you know, we are here to support, but we will also call you out when we need to call you out. But thank you very much for your time. Thank you, Vice Chair.
So the committee is to be provided a briefing paper on the use of corridor care and when this practice will end. There's an information item that's to be provided on the extension of virtual wards and data as to how they're being used. And another information item on the number of newly qualified and experienced nurses and doctors recruited since the CQC inspection. Other than that, I move that the committee notes the report.
Is that seconded? Seconded. Is that agreed, members? Agreed. Thank you very much. Thank you very much, Udo. Can I ask Sheila, Jackie, Adrian, Donna, Adam and Ed to come up to the top table? There's 6 of you to come up to the top table, please. 6 of you. Can I just say, the more people coming up, the ones I've called are the ones that are going to be talking, okay, for tonight. Is that okay? Because otherwise it becomes you're more than us. So we need to be, and that means then I come back even harder at you. So can we just make sure? Because the reason being is we haven't got nameplates for some of you as well. That's the reason. Although we do know some of you, so it's fine. Okay. Item 6, we have the update on KMMH. Adrian, you'll be glad I got it right this evening. CQC response on the all-age MH services transfer. Can I ask just for some introductions first, please? Thank you.
Shall I start? Jackie Cressati, I'm Chair of the Trust. Good evening, everyone.
I'm Sheila Stenson, I'm the Chief Exec of the organisation.
Adam Dorr, Chief Exec of the ICB.
Ed Waller, I'm the Deputy Chief Exec of the ICB and the Chief Commissioning Officer. Adrian Richardson, Director for Transformation and Partnerships for KMMH.
And Donna Hayward, Sussex, Chief Operating Officer.
Thank you, Donna. I suppose for you both, Sheila and Jackie, I mean, it's only fair, Jackie, for me to say, I mean, thank you both for coming this evening. If you want to just give us any highlight on the paper, that'd be really good. And Jackie, I would then ask you one question before we go to members. I'm sure you know I'm going to ask you a question anyway, but nothing to catch you out too dramatically. But if you can just maybe both of you give us something on your paper. Over to you, Jackie.
Yeah, thanks very much. I'll just say a few words. I won't go on, but I did want to say a few things. So good to be here. Very happy to answer questions. And I know that you raised a high level of concerns about our services. Take it very seriously. And I suppose the first thing to say is that I know that the quality of experience for the people of Kent and Medway has not been what it should have been, and I'm very sorry about that. I want to say a couple of things just before I perhaps address a couple of issues. And the first one is a contextual one, which is that the Trust is facing challenges around increased demands for services, workforce pressures, and that we operate models of care that haven't been changed for decades and that really require modernising. And I say that not to excuse poor care at all. That is not an excuse, but it is a context to demonstrate to you the sort of level of challenge that we're facing and the amount of change required. I mean, the CQC did find that we had some strong foundations, and I just want to highlight them because I know you want to talk about the concerns, but in terms of us being very much a learning organisation, but also very importantly, a very strong ethos amongst the staff around wanting to deliver compassionate care. The issue for us is that needs to be consistently applied across the whole of Kent and Medway. The second issue, just to bring to your attention, is that the commissioning decision around children and young people, mental health services and all-age eating disorder, that sits with the ICB, and it's not appropriate for the Trust to comment on commissioning decisions, but we can respond to your questions around assurance around the delivery and particularly around the transition period. And the board and the ICB do have a very robust plan with strong oversight and milestones and performance indicators around that transition. We in KMMH remain absolutely confident that this will result, this integrated service, children and adults and eating disorders, will result in improved pathways of care and transition for young people. And I know that has been a concern of the committee in the past. So very briefly and finally, just a couple of points about the issues that you raised last time. I think the first thing to say is the CQC report, along with our independent review that we'd already commissioned, really helped the board clarify the degree to which we were struggling with historic systemic issues around delivery of quality of care. And you could describe these, I suppose, as our culture. I would say specifically what we mean by that is issues of accountability around leadership capability and adjusting and revising the way in which we operate in a new context of increased demand and kind of a need for change. And secondly, and we're really working on all of that, and I know Sheila may want to say a little bit more about what we're doing about that. And the second thing is to just be really clear, you know, the CQC raised some serious concerns and the board acknowledges and accepts them. Absolutely. Now, they're not all the same and they don't all require the same response. So some of those concerns, for example, the unlawful detention of individuals in our place of safety required a very immediate, unequivocal response. The board, absolutely demanded that, expected it, and we had oversight that that happened. those other issues that I've alluded to, the sort of cultural change programme and the embedding of new models of care, will require a little bit more time, but needs to be really embedded in a sustainable way. So my final comment before I hand over to Sheila is that, you know, my role as chair is to ensure that the board reflects and learns on all of this, and that we really think about how we adjust our assurance models, how we make sure we think about different ways of oversight, how we really drive the improvements to make sure they're embedded in a sustainable way. Because we realise, you know, there are really two things that are uppermost in the board's mind. One is this consistent experience of good quality care that we need to achieve, and the other is building the confidence of the stakeholders in Kent and Medway around our ability to deliver that good quality care. So that's what I wanted to say. And Sheila.
Thanks, Jackie. So as Jackie's just said, and I echo and completely agree with everything she's just said, that we absolutely do take the CQC findings really seriously, and it's not a situation that we wanted to kind of find ourselves in. And since I've been chief exec, I've been very clear that we were going to be really open and transparent in terms of where we found ourselves as an organisation. And I know from the discussion last time, it might not feel like we have been with this committee, and I'm sorry if it's kind of come across that way, but it's absolutely been my intention that we would be open, honest about where we find ourselves as an organisation, the journey we're on, and how long it's going to kind of take us to get where we want to be. I just want to kind of set some context. So when we first come together as an executive team, so I've just been in post just over 2 years as chief exec, we came together at a time where demand was really increasing for our services. But also what we found was extremely fragmented pathways. So actually what we knew was we had to do some fundamental redesign of them pathways. Now I know the focus in the report and on the conversations with this committee in the past has been about our community mental health transformation, which is obviously a national initiative, which we've called locally as Mental Health Together. But actually there are other services we've had to redesign in addition to them ones as well, to make sure that the services we're providing within the, within Kent and Medway are what the patients need. So that's been a big part of our journey. I just wanted to kind of focus a little bit on kind of the community redesign and the mental health together piece. So as Jackie's already said, it's the biggest change that's been done in a generation, and that's not just for us in this patch, it's kind of, across the country for mental health services. But we've been very deliberate in our approach and also in kind of our design of that service as well. We've been quite different to what others have done within the country, but we chose to do that because we wanted to work with partners in a different way and felt that that was going to benefit our patients the most. So we really, as we started that transformation, we wanted to understand where we were as an organisation, and as Jackie's alluded to, the culture that might exist across our organisation, but the governance, but in particular, how we were monitoring quality and safety across the organisation as well. So we could take that assurance as the executive, but also as the board. So actually that's led us to having a very deep understanding around what's going on within our organisation. And, that's led us to having increased visibility around where we are with performance, around where we are with risk, using data, I would say, in a different way that we've never done before to make sure that we're being able to drive some change, but also the improvements we need to make within our services, and really thinking about kind of how we take assurance, as I said, through our governance processes, but in particular around quality and safety of our services as well. And, Siobhan alluded to this earlier. So we've placed a really greater emphasis on learning in the organisation, but also on listening within the organisation. And that's something I actively do as chief exec. The other day, Councillor McDonald, you saw, Adam was with me as we were out doing a visit in one of my services. And we all do that as executives. And we've done that more and more over the last couple of years to take our assurance by being in them services. So, and I just want to say that we knew this change was going to take time, and Jackie's alluded to this. It was about how do we embed that now to make sure that it's sustained within our services kind of moving forward. And what I always say to our staff is it's been a massive change that's felt like it's come all at once. But the important thing for us going forward is about how we do continuous improvement as an organisation, so it doesn't feel like we're having to do big scale change all in one go going forward. And it's really important that we set out at the beginning of any transformation the standards we're expecting, in particular around care. What I just wanted to kind of share with the committee is some evidence, I think, of the progress we've been making in the last year in particular. So our community waiting times have come down 10% in the last year, and that's based on kind of a growing demand as well for our services. The Medway waits in particular are the best in the county. So they're 9 weeks. We've got no patients that are waiting over 52 weeks within Medway either. So as I said, the best in the county. Our crisis teams are seeing people 90% of the time within 4 hours, compared to in September 2024 when we're seeing people in 80% within 4 hours. I'm sure Adrian would have touched on this before, but we've done a huge transformation of our memory assessment services in the last 15 months. And we've gone from being the worst in the country for our waiting times, which were 27 weeks when we started, to 12.6 weeks as we are today. And actually that's moved us from being one of the worst in the country to being one of the best in the country. So I just wanted to kind of share with the committee where we've been making conscious effort around improvement, and how actually if we're using our new approach that Adrian's been leading on, which we call Doing Well Together, which is all about improvement, actually it can sustain in the organisation and we can sustain that improvement. We've had a number, as we've talked about, CQC have been in. They've actually been in this week. They've been in with us today inspecting our health-based place of safety, our rapid response services and our home treatment services. And they were in yesterday in the West inspecting the same services. And we were expecting them to kind of re-inspect some services as we move towards our well-led that's going to be in the first week of March. So I just wanted to kind of share that. Some of the external reviews we've been having as well have absolutely reinforced that they can see there's a learning culture that's growing and strengthening in the organisation, and that there is a culture of continuous improvement that they can see that's developing as well, which is what we're absolutely striving for. I just wanted, before I pause, to make one comment about the kind of children and young people services. And I just want to be really, really open, as Jackie said, from the commissioning point of view, I'm sure Adam and the team will pick up. But for us, from April, it's about lifting and shifting them services from North East London Foundation Trust back into our organisation and back into Kent and Medway. And I just want to stress to the committee, it's going to be the first time ever that children's and adults mental health services have been in the same organisation within the county. So I think that's really important kind of step forward. The transition is going to be all about stability and about how we do that safely. It's not going to be about transforming them services immediately. And in the first year, it will be about embedding that service and the all-age eating disorders service back into our organisation. A priority, as Jackie's already alluded to, is going to absolutely be about that transition from children's and a younger person into an adult's mental health service. We're working really closely with the ICB, with NHS England, and obviously, of course, with NELFT about having our clear transition plan and milestones and taking assurance from where we are to make that transition in April. But, you know, I welcome kind of any questions. And I just also wanted to say to the committee, you know, I am happy for you to come in to see our services and see some of the changes we're making at any point. So just wanted to kind of, you know, offer that opportunity to come and visit any of our services.
Thank you, Sheila. And before I go, I'm going to go over to Councillor Perfect first, because but I did say, Jackie, I just wanted to ask you a question. It's only fair if I did. Thank you for your openness. I just want to say first of all that Adrian, and I know Donna got the brunt of it on her visit with us last time, but I've got to say that Adrian and the team have gone through a lot with this committee, but worked really well. And I've got to say, Adrian has definitely had a brunt of this committee for a long, long time. And I suppose, Jackie, I'm going back to the reason he's had all of that is because the story never changes here with regards to something going wrong. Now, I know your staff are great. You've got some good staff like everywhere else. You've got some good staff. It's a very difficult area that you're dealing with, I know. But I've been on this committee since 2015. And since 2015, every time you've come to the committee, it's been a governance failure. There's always a governance failure. So I suppose it's only fair if I say to you, like I did to your committee, are you proud of your board? I'm going to say it to you, Jackie, because your board, every time there's been an inspection, it's been brought out on culture, on governance, on everything. We've always been told that that's all going to change and it's all going to get better. And I'm not saying just under you, Jackie. I know how difficult a board is and how difficult to turn the tank around sometimes because you've already said there's a lot of stuff ingrained in an organisation. But it hasn't changed, and that's why and Sheila, I appreciate, that's why there's frustration, and we will come to it shortly, but there is real concern over the ICB and over the contract shift. There is from members. We can touch on that, though, and we can give some reassurance on that. But there is real concern over that ICB decision from members. But I think it's, before I pass over to Councillor Perfect, I just want to ask you that question. That it's always governance, always something going wrong.
I do understand where you're coming from. I think what I would say is the point that nothing ever changes is not quite right. That a number of things improve, but there is one thing I think that we have not absolutely nailed, and that's really what the current programme is all about, and that is what we've previously done, which is very much an NHS habit, which is a problem crops up and we go in and we have an action plan after the event and it appears to resolve, and then a problem pops up somewhere else. And I think that's what you've seen. And what I would say in my time with KMMH is that there used to be many more surprises, so we would be caught out which is absolutely what a board doesn't want. Whereas I think in recent years, we have not been caught out in the same way with surprises. But what has become increasingly clear is that our actions after the event are not the kind of systemic actions that lead to sustainable change. So what I do agree with you is that we absolutely haven't nailed the question of consistent quality of care across what is a huge patch. I do agree with that. But that's my analysis of so things have shifted, and what's important about the current situation is that we're absolutely not doing that, trying to kind of close the stable door after the horse has bolted. We're really holding back from that, and the board is really encouraging the executive not to get into that. Slight pressure sometimes from the CQC to do that kind of thing, have 28 actions rather than 2 or 3 big kind of system ones. The only other thing I'd add, which I think is a fair challenge, and Sheila and I have been talking about this, we have asked an external company to look at our quality committee because we do think it needs a bit of a review. So, absolutely accept that. Very difficult to get the right kind of triangulation of data, but we think I don't know if that makes sense to everyone, but triangulation of data we think might be the thing that will help us going forwards, and so we're really working on that. So it's not quite right at the moment.
I think I'm going to pass. I think maybe we can come back to it as we go around members' mouths, the question, but it's around, the culture as well. Don't forget, we've had bullying of staff. We had loads of stuff over the years. It's not just one thing. There's been a cultural thing across the organisation. But we can come back to that. But
sure.
And I'm going to go to Councillor Perfect first, and obviously I will say KMPT, but KMMH, it might be where you want to start, Councillor Perfect.
Thank you, Chair. Yeah, I think, thank you very much for coming here. I think last time I was pretty firm with your Deputy Chief Executive and with Adrian. And in fairness, actually, a lot of the points I'm going to raise now didn't sit with them. It sat with you, Jackie, and your board, to be fair. Because, I'm not impressed. I don't think residents are impressed. Since the last time we had this meeting, there was a lot of press coverage. I had a number of people write to me and they share similar concerns. So I'm just going to go through a number of questions, and I appreciate Adrian and Donna, you've heard these before, because I think there's still some points, and I think the chair started to reference those, that I don't think have been answered in this report. And actually there are some things in this report that make me even more concerned. So I just wanted to start with just around sort of the organisation in its current form. Obviously, you've just acknowledged that the organisation has got a number of very clear failures. You had a CQC report that was very poor last year. We've got concerns that have been raised throughout that report about safety. Obviously, you've acknowledged that you're working on an action plan and working through those. At the same time, your organisation decides it's a good idea to spend £250,000 worth of taxpayers' money on rebranding the organisation. Now, I understand the defence that has been put out, that it was planned and it was a good idea and everything else. My concern is the impression that that gives to our residents. When they pick up the Kent Messenger and they open it up, and on the second page, they read about a failing organisation that's got a CQC report that's failing, and it thinks, the board seems to think it's a good idea to spend £250,000 of taxpayers' money rebranding the organisation. So that's my first question. Might not seem particularly that important or trivial, but it's the impression that that creates to our residents about the NHS and about services that they are being provided with, because it gives an impression, and I think it doesn't just give the impression, I think it demonstrates a clear strategic direction from the board that is misjudged and misguided. So that's my first point. My second point is just around, as the chair's referenced, around the point in your report here, which is 2.1, which talks about leadership and organisational changes. So we've just had the point that I've just raised around the CQC inspection. At the same time, we've then got you advertising for a joint chair. I don't know, Jackie, whether you're interviewing for that role or whether there's going to be a change of leadership of the board. So we've got that change happening at the same time as we've just had all of those issues that I've just raised with the CQC report. So that's my second question around what is actually going on in terms of governance, board. We've got numbers of terms of references ending. I'd be very interested to know what personnel are going to be changing, because obviously we might get reassurances from you, Jackie, but obviously in 3 months' time we might have a different chairperson here telling me that they want to change the name again or do something else. So that's my secondary point. And then my other concern is just regarding the children's services. So just, and it
Councillor
layers
Perfect,
from the...
Shall we let him answer the first?
Well, I was just going to make this point, because it layers, it's almost you've got the first set of issues that I've raised, we've then got the second set of issues around changes of governance, and then we've got, at the same time as well, an organisation that's trying to take on a whole nother service that it's never run before, with no experience of running. And from the report, I'm not clear why an organisation that was failing would go and seek to take on more services that it's never run before. And I used the analogy at the previous meeting of our local academy trusts. We would not expect the Department for Education to be retendering failing schools led by failing academy trusts to other failing academy trusts that are struggling to get its existing house in order. So, and again, that comes back to the point about the public perception in the press around, we have an organisation that is clearly failing, has now got governance changes and a whole raft of people changing roles and new people coming in, and then you couple on top of all of that, we're then going, let's go and take on more services. So I would be interested from your perspective, Jackie, around what the board's thinking was in that timeline and how it thinks, I guess, the capability to manage the pace of change of everything that you're doing at the start, changing all of the non-executives, and then at the same time taking on new services. Thank you, Chair.
Thank you, Councillor Perfect.
Let me have a go and come back if, I haven't answered your question. So on the brand, just a point of clarification, the board ultimately agreed a sort of maximum of 250,000, but we spent 90,000. But, that's just a small factual point. And, the board had some of the discussion that you're raising, and I think brand, I know Kendra will be, she's itching to speak, but our Director of Communications, but, brand feels like it's about logo and signposting, when actually there was a much more kind of fundamental ethos around this whole business about trying to change how we saw ourselves, our ambition, building that accountability. So it was part and parcel of building a sense of KMMH as an organisation with ambition and building accountability and engagement with the staff. to empower them to be part of an improving organisation. So the board had a lot of discussion about that. They raised the issue of the money. But on balance, we felt it supported that ambition to become an improving organisation with a more coherent kind of philosophy, a model of change. Now, you may disagree with that. I absolutely understand that. And I do understand your point about public perception. But from our point of view, we had the discussion, and on balance, we felt it supported the building of a better organisation. The joint chair point. So just very briefly on a personal note, NHS England is very tight, about 10 years. I'm coming to the end of my 6 years. I cannot do any more. It won't be me. The joint chair role is really about saying that longer term, over the next 3 to 5 years, we really want to improve the outcomes for people with long-term conditions in particular, who are shared between the community service. We share about a third of our patients together in mental health. They have poor outcomes, as you all know, in terms of quality of life and so on. And we feel that by coming together and doing more together as separate organisations, but doing more together, very much in the DGT MFT model, that we can do better for our patients. To do that, the model is that you start with a joint chair who can really keep the strategic hat on, whilst the chief executives, who will not change, will be both working together with the chair on strategic ideas, but actually remaining very focused on embedding, the important work in the organisations. The only changes that there might be, there are none currently planned, I think. I mean, we share 1 or 2 staff. There may be a little bit more sharing of some roles, but we're very mindful of your point, which is well made, about, well, my interpretation of your point, which is about capacity and bandwidth and not taking your eye off the kind of core quality issues whilst trying to think strategically elsewhere. So the board has been talking a lot about that. We've been supporting Sheila in thinking about, do we need to expand the team slightly? What's our capacity like? But so major changes are not envisaged with the joint chair. It's a strategic kind of move without any desire to disrupt what are kind of big immediate agendas within both organisations. And the third point about NELFT services, CYP, and I'm going to challenge you on us as a failing organisation. I don't accept that. We have failed in certain areas. We have challenges. We have problems. We are apologetic to you about some of our failures of quality of care, but we are not a failing organisation. We have areas of excellence. We have talented staff, and we have considerable feedback also that we're doing a good job, but it's not good enough. Absolutely. So I'm not being defensive about it. It's not good enough because it's not consistent, and there are some serious areas of problems. So I'm pushing back on that bit. The issue about taking on the organisation, I think we're sort of slightly stepping into ICB territory because, of course, the first step was the ICB's decision. Obviously, that was discussed at board, and I can assure you that one of the major early discussions was around our capacity to take on children and young people, the risks associated with that, and weighing up the costs and the benefits and how best to do it. So clearly, we were thinking, on the one hand, what are the benefits for children and young people in particular? The benefits are considerable about having an integrated all-age pathway, which don't need spelling out to you, I'm sure. But, considerable benefits around that to improve pathways of care. There are risks. There are risks around capacity. And actually, from a personal point of view, having in the past had experience of taking over services through a sort of what you might call a cliff edge kind of tendering process, This has been a very different experience of collaborative transition process with NELVT and the ICB that has meant that the board, who scrutinises every aspect of the plan every month very rigorously, the board are assured that we have a really robust process. We have a strong relationship with NELVT, and so that transition is going to be as the result of a year's worth of collaborative working. I'm going to stop there.
Jackie, can I,
yeah.
Councillor Perfect, I'm going to help you with your next section, I think, because it'll help all members. Adam, we're talking about, and Ed, we're talking about this process. There is still some confusion around the table, as you do know, about this process. And the main confusion that keeps coming up, I'm sure you can hear it, is about, Jackie, I know you're saying that's down to the ICB, but it is going to be an SV, and your team are going to have to come back here and report on that service regularly, because we've a substantial variation has been put on the service. So I know you can say at the moment around the decision it's the ICB, but when it comes to holding you to account, we'll be holding, as Adrian and that, we'll be holding you to account on delivery, and we'll be holding it very stringently. Adam, Councillor Perfect is asking these questions around, I suppose, aimed at the ICB, around an organisation that the ICB know of that are failed at CQC. And I know when you say about the organisation, I think Councillor Perfect is stating about the CQC thing, where it's saying not safe and etc. And even in your opening, which you've done very well, Jackie, but even in your opening and yourself, Sheila, you are saying that you're under pressure, there's a lot going on, you're dealing with archaic structures, etc. So you've already listed your issues. I suppose, Adam, do you want it will help Councillor Perfect, I suppose, about the ICB's decision in this, because it wasn't a procurement, in this transfer.
Sure, thank you. So I'll take the second paper as read and kind of cover that now, so that we can then get into a broad discussion, if that's okay.
Is that right, Councillor Perfect? It would help you then come back, yeah.
So what I'll do is I'll just give a reflection on what I've heard so far about readiness, and then I'll ask Ed to talk through the process, because as you're aware, I wasn't in post when the decision was taken. However, when you are the commissioner of a health service, you look at a number of different things to therefore give you the assurance, where do you think things are at. So when I was first joining in this post, the first chief executive I spoke to was actually Sheila, in terms of my thoughts about what needed to happen. And what I was really struck by was the openness and the honesty about where the trust was at, that you don't always find in all organisations. And that is a very important thing. It's not completely easy to sort of measure, but you get a feeling for it. And what I think was quite clear, we as an NHS in Kent and Medway have to find a new way when we get a CQC inspection, because I think it happened, but the report came quite late in terms of it. What the obvious question I asked Sheila when she told me about this CQC was, but did you know already? And she was able to show me all of the work the trust had been doing prior to that to already get on top of that. So that tells you a thing. That tells you, did the organisation, was it steering in the right direction when these things happened? So that's I think, the first bit. I also look at performance. So recognising that some of our residents today still are not getting what they need to get. I accept that absolutely. I think it is important, though, to look at the improvement that's happened, particularly in the last 12 months, in terms of memory assessment, the length of time people are waiting. And whilst it is really important we look at these things from a Kent and Medway lens, I have also a job to compare across the country to say, do we do better or worse here for the comparative spend? I think I also covered when I first joined you on my last meeting, I'm doing a piece of work to understand the allocation of resources across the system. And I think I put in my last report to you, the current allocation of resources would be 2% more than most comparative groups on acute services, and 2% below that on mental health services. That's adult and children. So the Commissioner has a responsibility to try to rearrange that over a time period. So for me, as I look at it, first of all, I then go, okay, so I arrived here, the decision's been taken, what are we going to do about that? And there's been many questions asked about the procurement decisions, not just related to this, but others for the ICB. And I covered in my last report to you that I've commissioned an external review of all procurements and contracting to strengthen that going forward. And once that is complete, I can imagine we'll have a big and fruitful discussion about what that report says. The decisions taken within this are also part of that, being really open about that. What I can assure you is the decisions taken, from my perspective, are compliant with national guidance. They are legally appropriate. However, there are different ways by which we can do these things going forward, so I recognise that. In relation then to the readiness assessment, because in reality, we are transferring, it is coming in 10 weeks, and my job is also to say, how confident am I to do that? And when I joined the team, I think the team would say they got quite a rigorous check and challenge session from me about, you know, where are the risks? How do we do that? I've spoken to Sheila directly. I've spoken to our counterpart at NELFT. I've worked very clearly with the team to establish what the issues are. There are some risks. They're in the paper. Ed will cover those in a second. But as a commissioner looking at them, they all feel completely manageable for a strong go live on the 1st of April. There are 3 key lines of inquiry that I'm still discussing, both with Sheila and Jackie, which are, first of all, what is the go live position in terms of, are we really confident that there is a strong go live? To do that, we've jointly agreed that the Trust is doing some due diligence on the services that they inherit. Once that is complete, I would expect that is shared with you, and we will share that together, because we're trying to demonstrate we're one NHS here. And in that context, it will also show things like 50% of the doctors in the current NELF service are interims or locums. So we want to be really clear, what did the Trust inherit, so that there is no ambiguity going forward about the journey to go on. And there are still significant improvements in the NELF service that if we were not transferring, I would still have to tackle as Commissioner. The second thing, we're really clear that, that any changes to the model are subject to due process and consultation should they meet that threshold. But we are also very clear in our work with the local authorities, integrated neighbourhoods are where we're trying to improve care. We discussed that a lot last time. So with that, we're really clear that if a third of the patients are on a community physical health caseload and a community mental health caseload, there is benefit in saying to those communities what comes together. And to give children a good start in life in Kent and Medway, we believe that the best model to give them a thriving chance is to have an all-age mental health process to get right. The third bit is, of course, I have responsibility as the Commissioner to go, does the organisation that I commission from have the bandwidth to do everything that it needs? And the discussions we've had are what will be the strengthened processes that therefore you're going through to therefore make that work. But it is important at a senior level within the NELF contract, those senior staff are also transferring over into the service. But Ed, do you want to just give a bit of context for the...
Adam, let me just come back to Councillor Purvitt.
Sure,
if Ed can come back on, because that's the second page.
Sorry.
I just wanted to help Councillor Purvitt. I'm sure Councillor Purvitt's going to come straight back now on some of the answers. Councillor Purvitt.
Yeah, thank you. I mean, if I just I'll come to you in a moment, Adam. Just to come back to you first, Jackie. I mean, look, I know the comments that you're making. I think, look, on the first point around the rebrand, I mean, I think you should have just communicated that clearer around the money back to the population. I think, you know, I understand press points can be misleading sometimes, but I think it's really important to residents. And at the end of the day, you know, we're elected by residents. My job here is to represent my residents. And you know, to them, the impression is not good around rebrands. And I think, I mean, I personally wouldn't have done it, but that's a decision for your organisation. I think just on the second point regarding the organisation in terms of obviously its capacity, and also the point you made around strategy. Obviously, you're saying that the strategy won't change, but with the greatest deal of respect, yeah, any chairperson, you know, your successor may come and say, actually, they've got a different view in terms of the organisation. And I respect that, but I think, you know, that's something that the committee has got to be aware of in terms of key personnel changing, and that happening at the same time as you taking on a very significant contract. And in terms of obviously the organisation, this CQC report was clear: inadequate, requires improvement, requires improvement, requires improvement, requires improvement. So I reflect that you're making changes, but until such a time as I receive from the government's independent regulator clarity that that is good, I'm not going to be completely comfortable with the way in which the organisation's being led. And that's the reason why we have regulators in this country, to provide reassurance to the public around the services that are being provided. Happens through the CQC with yourselves, happens with Ofsted, with our education providers, and a whole heap of other regulators, Ofwat, etc., that regulate other services. But it's important for us to view organisations through those means, because that's what Parliament has laid down in terms of the regulatory framework. I think just more widely around some of the points that you made in terms of the capacity within the organisation, I think I would be interested in future reports to learn more about how the board is going to be reviewing the sort of children's contract, and how exactly you're going to fit that into the work programme alongside what you're doing. If you're going to be doing a skills audit and identifying additional non-executive directors that might sort of support that transfer of experience of those services, I think that might provide some reassurance to the committee, and I think that would be appreciated. Just coming to you, Adam, in terms of some of the points you're raising. I mean, I totally understand where you are coming into the organisation, and I think obviously you've got a piece of work to do. And actually, NELFT aren't providing an outstanding service by any means in terms of what it's providing back to the public here in Medway. So I note that. I think I'm still completely confused as to why it was undertaken at such the speed it was. I think we still have no idea why that happened, and unfortunately your predecessor didn't exactly have a reputation for openness and transparency around some of these things, I think, putting it mildly. So I note the points that you've made. I think we just want people in Medway to have access to good services, and people to have reassurance. And we were out recently talking to some residents actually in Princes Park ward, and one of the things residents raised with us is, why is the NHS, why has everything got to be inadequate? Why are people in Medway waking up every morning, have got a hospital that's getting RI or inadequate with all the issues that it's got in the press, got mental health services that aren't performing? There is this general perception, and yes, some of it is media bias, and it's not all completely correct, but there is, in Medway at the moment, the services are just not performing the way they should be. And then we know all the reasons why that's happening. But I really do hope at some point I might wake up in the morning and go, we're like Maidstone or somewhere else in the country that has got a good performing hospital, good primary care services, and people are able to sort of live and feel comfortable. So I think that's just the wider point. But I do note the comments that you've made in terms of that process, but I think we do need, from the ICB moving forward, more transparency around the procurement. I'll be very interested in that review that you're undertaking, because I think that will provide some reassurance both to members of this committee, but also to members of our Children's Committee that I know have serious concerns about the way in which that procurement process was handled. Thank you, Chair.
Thank you, Councillor Perfect. Councillor Cook.
Yeah, thank you. The first thing I'd say as an educator is, we have this mantra that children only have right now to be children. And for this cohort of children, this is the only time they'll be in this year group. So although it's really, really important we do the change really well, and I can see these are massive things to change, we are letting down children in their only childhood. And the mental health of our children and young people is one of the biggest areas of concern that I hear from fellow educators and that I hear from my residents, and also that I feel myself. So as a bit of a way of background to that, one of the biggest areas of concern, I think, in children and young people's mental health, both personally and in some of the groups that I represent, is in diagnoses, and particularly diagnosis of ASC and autism. So I have a daughter. I've got permission to share this with the committee because she would like people to know. She went to a small primary school and lost the end of junior school to COVID. So she walked into a secondary school without a diagnosis. As soon as she walked in, the secondary school asked why she didn't have one. She's choosing her sixth form right now. She still doesn't have one. The impact of that means that we are, firstly, creating greater mental health concerns. And secondly, we are missing opportunities to treat and support and prevent things that would cause mental health concerns for our young people. So some of the questions I want to ask are related to personal issues, some are related to wider issues of constituents and wider people that I've spoken with. Ultimately, our children want to know who they are, and they want to understand why they feel the way they do and how they can get better. And if they don't have access to support to understand who they are and also support in their daily life, when they are then treated for the symptoms, they can't be treated properly because there isn't a language around that child that is joined up and coherent. So firstly, there is a huge lack of communication with our parents. And I also say that as a member of the NELFT Parent and Carer Forum. And I know that's something NELF have worked with, and I really plead the committee here to hear that and to continue to work on that, because that then has a profound impact on the mental health of our parents. So when I'm hearing this joint up approach between the mental health of children and young people, the transition into adulthood, and the mental health of isolated adults who are trying to care for complex needs, often in the night, in the evening, when they're tired, when their children are tired, they're around sleep, they're around physical care, they're around high anxiety, they don't have a language, they're offered parent-carer forums, and I've just been checking on my phone, they are usually 1 till 2 or 11 till 12 in the middle of the working day, when parents that are also trying to hold down jobs can't access that support. So that's really significant. Secondly, we are missing something around whole person care where our mental health support isn't able to be there. So for example, the sort of issues I've seen have been issues around sleep. GPs prescribing generic sleep advice for young people for whom mental health and ASD is the reason they can't sleep. It's not a coherent joined up approach. Physical needs around bladder issues, around self-care, and significantly around eating disorder. Which leads me on then to my third concern, that our children are going through multiple screenings, particularly through our CAMS service right now. If they're being treated for something, they're screened for that. And then that doesn't count for the next thing. And then that doesn't count for the next thing. And so they're weighed, but they have an eating disorder. And so they're given a sensory screening, but it's not going to count for their autism. And I cannot tell you what it feels like to have your phone ping and it be NELFed when you've been waiting 4 years for a diagnosis, for it to be another invitation to a lunchtime support group. It is very, very difficult. So my concern tonight, to sum that up into a question, and thank you, Chair, for allowing me to say this, you speak about continuity of care. I don't want continuity of care. I became a counsellor for several reasons, and this was one of the biggest, because we are losing our children and young people, and we are letting down whole swathes of the population of our adults because we aren't getting this issue right. And I understand it's a national issue, but we're talking about Medway. So when we talk about continuity of care and handing over my data, I'd like to know how that's going to improve. And yes, I want reassurance as a counsellor for the children that are growing up and going to be young people in a few years' time. But I really need some confidence building around our young people now, because otherwise our schools are having to fill the gaps, our parents are having to fill the gaps, and the treatment that our wider healthcare service, dentistry, we've spoken about loads at this committee, taking a child with undiagnosed ASD or diagnosed ASD to the dentist, as a parent, how you do that when they don't even have a diagnosis, let alone any help to support them, it's so difficult. So I really appreciate you allowing me to share my personal experience, and thank you for listening, and I'm really keen to explore that further. Thank you.
Could I say something? Thank you for sharing that, and because it brings it alive for us, just what it is like to be a parent in that situation. I'm not going to be able to, respond in the way you deserve tonight, but there are a couple of things you said, and I thought maybe I could pick up on. So when we talk about some of the benefits and why KMMH felt that the whole, the kind of whole age trajectory and bringing it all together was important. You made a really important point, which is that there's both the parents of children with mental health problems, and there's parents with mental health problems who have children. And at the moment, it's very separate, and we can't join it up well. And one of the things when I went on a visit to Highlands House, where there's NELFT in the basement and KMMH, you know, and the rest of the building. And, you know, one of the ideas there was to say, look, we're all in the same building. What are the potential, what are the things we could do here about bringing that all together? So I just give that as an example of why there might be a benefit. Now, I appreciate your comment about pathways, but in terms of integrating, that's a great example of how we could get things better. Your point about diagnosis, I think what you're really talking about is timely access to support and not letting diagnosis get in the way of that, or being the necessary hurdle, or the, you know, having to wait years for it.
Chair, if I can just clarify on that. If you don't know you're autistic and you're an autistic person, it's really important to know. So yes, I hear, I don't want to just interrupt there, but actually knowing that you've got the label is crucial if you're autistic. So just to add that clarification, thank you.
Absolutely fair. But it's something about timely access support and not letting diagnosis or problems about that get in the way of it. I suppose and I agree with that. And one of the things I suppose I'm thinking for the committee is that once we have got the transition in place and we're into May and June, our board had a very helpful presentation from NELF staff around their pathways and how they're thinking about their services. And I just wonder whether that's a helpful thing. I mean, it's very much up for you, but whether that's a helpful thing for us to support them to come and really talk with you. And where, of course, all your points would be, you'd have them there to really challenge them.
I mean, I think, Jackie, first of all, Councillor Cook, yeah, you couldn't have put it. Thank you so much for putting it over, and that's a big thing for you to do. And it was an honour to give it up, that opportunity. You needed to do it. I think for me, Jackie and Sheila, I think, I mean, we have the reassurance, and Adam as well, we have the reassurance anyway, because Adrian knows the drill. We can call you back to every meeting to ask the questions about NELF, and probably will be asking questions about where you are in your CQC journey. I suppose, and correct me if I'm wrong, Esther, Councillor Cook, sorry, what Councillor Cook has, the points you just made, and especially for the ICB, is your reputational risk on this, right? Because everyone can sit and make these decisions, and I will touch on when it comes to me about the August notes here, which are not quite correct. But everyone makes these decisions, and we hope that whatever service takes on a new service can equip and can do it. We're not saying you're going to be able to drop them waiting list down to 1 year or from 10, you know, we know the pressure. But this isn't just, which you made it very clear at the beginning, Jackie, and I suppose it's a good move, really, you did, because this isn't just a KMMH issue, because you've got to make sure you do this correct. This is also on the ICB, Adam, because the ICB have made this decision. You can't just blame it on the contract, on the person you give the contract to, because the ICB have made the decision to hand this over. I mean, I'm just, you know, from a person, and Esther's, Councillor Cook, sorry, tell me off, Councillor Cook. Councillor Cook is just an example of what we have out here in Medway. That's just what, you know, you've got it, luckily for us, we've got it around the table. But reputationally, it's a difficult one for you, Adam.
Can I just respond to that? And I want to thank you, Councillor, and thank your daughter, first of all, for allowing us to hear her story. So thank you very much for that. A few things for me. So first of all, the reality of this is, as you've described it, is the lived experience of many children and young people in Medway today. So the first thing I look at is, do we have an agreed cross the public sector approach to children's mental health service, embedding them in all pathways? I think we've got to take a piece of work away to actually get that right. I'll be really frank, I find that much easier to do when I've got a provider who's going to lead the all-age services and is a Kent and Medway-based provider. I think it does make that an easier conversation. But also, we've also got a piece of work to do as part of our planning round for next year, because you've asked the obvious question. This may all sound great, but what about now, right? So let's answer that. So we're doing a planning round at the moment. We're working with the trust about what we can afford, what we can't afford going forward. And the team are all very aware that I'm very clear about children's services in general. What is the approach for that? So it's things like, can I have the competence about mental health support workers in schools, those kind of areas. So I think when we come back with our annual plan, based on how we want to work differently with people to say, these are the things we can do this year, these are the things we can't, and of course we expect scrutiny on that. I think we should describe to you, this is what we think will be better in a year for children, because what I've taken from you is that every year what will be different for that cohort. So thank you for that challenge. And the reputation, it lives and dies by how open we are, to be frank. I covered this last time and I'll repeat it again. I said that how we're working together, we've come together tonight to try and make sure that there's not a bit of each different part of the system blaming somebody else. We're trying to be really clear who's got responsibility for what. That already feels different. I've been given feedback on that. But I did say we would get this kind of, we try to make sure that we are very rarely getting it wrong in that kind of engagement bit by the end of the financial year. And I think already how we're working together is starting to demonstrate that. But I know this committee has trust and confidence issues in the ICB. It's my job to work with the team to therefore build that going forward. But it's not going to happen but just from me saying it, it's going to happen by me coming back with the things I've agreed to come back with in an open way, in good time and getting that right. But I've got good commitment from all NHS organisations, how they want to reset the working relationship with this committee, so we can therefore make sure we can be scrutinised appropriately, but also do good briefing in good time going forward.
Can I just ask before I go on to the next one? Can we just have some, Sheila, would you mind, can we look into that maybe when your service comes over, or Ed, about these lunchtime things? I mean, that's a really good point. I mean, how can working parents and stuff like that get into a 12 till 1 or 11? It's ridiculous. I mean, surely that's an easy thing to sort out. If nothing else tonight, we should be able to get some response for that, surely, hopefully. Ed, you're looking at me like that. Very, okay, thank you very much. Are you okay, Councillor? Is that?
And just say, I do appreciate how many of you are here and the seniority of people. And I think, you know, for the committee, it is noted. So thank you, Chair.
Thank you, Councillor Cook. Councillor Shocker.
Yeah, my question was around the improvements in the waiting times. It was really good to hear that part and being on the right end of the league table now. And what were your biggest learnings for you that came out of that and the progress you made? Do you feel you can assure us that this level of waiting times can be maintained or improved? And if not, what do you envisage going wrong again?
If I start, and then I'll probably pass to Donna. I think our biggest learning is the focus, is what I was saying at the beginning, actually, about how we use data in the organisation. And Jackie alluded to this as well in terms of leadership and our development of our leaders as well, which is actually, it's really important you're using the data so you know where people are in the waiting list. So I think that's been the biggest learning for us. I think we've had to make sure that we're providing the right information to our leaders as well, so they can lead their clinical services and they've got everything they need, whether that be about where they are with their workforce, whether that be where they are with their budget, but in particular where they are with their waiting times, and setting up, and Donna will go into the detail, in terms of that rigour of being able to monitor waiting times a lot better than what we have before. So I think that's absolutely what we've done differently. And we also have a fantastic service director within the North, which is where Medway sits, who drives that through her organisation. And I spent some time with her between Christmas and New Year, and I could see that when I was walking the services with her as well. So it is all about leadership and about how that's kind of, you know, cascaded through the organisation. But I'm sure Donna might want to add.
Yeah, thank you very much. Thank you for the question. On top of the data, as Sheila's just described, I think the biggest learning for Medway has been the use of the voluntary sector. They've really taught us something in this transformation that we've been doing, and I'll just expand on that a little bit, if I may. In sort of traditional NHS mental health services, I think we're very risk adverse. We get very anxious about risk because it's part of what we do every day. And in a way, that prevents us from seeing how people can be supported in a different way and using the assets that they have and much more in a recovery type model. And when the inspectors came out, we were kind of halfway through our transformation. We were still piloting some of our services. And what we hadn't got right was the voluntary sector piece right at the front door, supporting us with our triage and our assessments. And in Medway, we've had our partners doing that with us working alongside them so that anybody that's presenting with a high risk, complex mental health needs can be seen by our team very swiftly. But actually the benefit of having voluntary sector partners that also know the community assets really well has been enormous. It's been a real game changer for us in Medway, which is why we've reduced those waiting lists in the way that we have.
Thank you, Donna. Thank you, Councillor. I'm going to, Councillor Jackson, I'm going to end with Councillor Wiley. Councillor Jackson, just put your question.
Thank you. I'm interested in the DNAs because I don't condone DNAs and I know they cost a lot of money. But I think it's just when we're dealing with young people, the way we approach stuff with them can be more damaging than we think it can. I'm going to do the same as Councillor Cook. A bit. My daughter received a letter. She's 23, but she's got learning difficulties. So she had a mental health learn. She received a letter with her name and the date, no place where she had to go. And then I'm looking at it now, it's still now, a 4-paragraph bit about she's having a high demand. If she doesn't make this appointment, her care will be cancelled and go back to GP. She then went, because there was nothing on there to say where it was, she went to the heading letter. She arrived all the way in Dartford and was then told, no, your appointment was in Gillingham, but they looked at the letter, it doesn't say on there where it was. She is now frantic that she's been waiting for this appointment and now her appointment's going to be cancelled and she's going to have to go back to the GP. That in turn made her start self-harming because she now thinks she's going back to the pile. They accepted it was their fault, they hadn't put the address on it, but every single letter she gets, it's still, she goes on Thursday, it's just her name, her date, the appointment time, now where she's got to go, and then this paragraph. And when we were talking about before, and I'm reading about the DNAs, and it's saying that you do have the next step and you are chasing them up, I'm just worried because we talked about missing people last time. How many of these DNAs are being followed up? Because people with mental health, some days they can go on for weeks, they can't get out of bed, they don't want to talk to anyone. Are we following these up, or are they just becoming missing people and being referred back to GPs and no one's, because, you know, and what's happening, because they will worry about it as well. I know that if they've got that letter and 4 days later they come out and they decide, they've missed that appointment, they won't phone up and chase it up because they will just think, oh, I'm going back to the GP again. I talk to young people with mental health issues all the time. And this is what worries me. Are we really chasing these DNAs up, or are they just becoming one of them missing people we talked about last time?
Yeah, thank you for those questions. Look, first and foremost, I'm really sorry about the letter, genuinely, because it's not good enough. And I'm very happy to personally see the letter if you'd like me to and actually take that forward, because we are working to standardise the paperwork that does go out to our patients and their carers, and it is something that I'm aware of isn't where it needs to be across all our services in a consistent way. So I'm very happy to pick that up personally. The second issue in relation to DNAs, and it's a really important point that you raise. DNAs for us can be extremely challenging, not only because obviously the person is often booked and that is a space that's not being utilised, but also because if somebody's not known to us, we don't really understand why they might not have come to us in the first place. So there's a different thing here. There's those that patients, if you will, that we know really well, and if they DNA, we might have a history about why that might be, and we might know how to make contact with them to encourage them to come back into the services. And then there's the new referrals, and that's where the highest DNA rate has been, with those that have never ever come into the service. That's really challenging because we don't know the patient and we're reliant on what's in the information that's been given to us. But we have introduced a meeting, a daily meeting for our community services to track people who haven't attended their appointments. And on some occasions, we will even get into doorstepping people if they haven't attended their appointments because we know them. Those that we don't know, we will make several attempts to try and engage with individuals to try and encourage them to come in. And again, I'll go back to our partnerships in our community services. So, you know, we've had terrific learning from our voluntary sector colleagues, whereas we might be very traditional in our approach, sending letters for somebody who might not have attended appointment. They've taught us we can pick up the phone and have a conversation and do it quite differently. So those meetings happen every single day in our services around people that have DNA'd, so that we can do our best to make contact with those people, especially those that we don't know what circumstances are that they've not attended.
Thank you, Donna. Thank you. Councillor Jackson. Is that
Can I
okay?
just quickly follow up? When she actually did get in to see, she was, I can't say the actual person that she saw was second to none and was really good, but it was just, but if I hadn't have been there, she would never have gone to that appointment because she would have just thought she'd have been referred back to GP.
Thank you, Councillor Jackson. Councillor Wiley.
Thank you. I would, excuse me. I would like to go back to the beginning when, as chairperson and chief exec, you gave a presentation, and between you, you use the phrases, the situation we find ourselves in, not where we want to be, and fragmented pathway. Now, you find yourself in a situation of your own making because you've been in charge of the adults for a very long time. So to say it as if it's come out of the blue, it just gives the wrong feeling. All of those phrases give the wrong feeling to me. And when Councillor Perfect said you were failing and you fought back against that, which, as you should, but you have failed people. You accept that you went from the worst to the best with the appointments and times at present, but you were the worst when, you know, you were in charge. KMPT were working the service, so you failed a great deal of people, and we hear from those people, and it's very hard to feel forgiving, and to use trite words doesn't sit well. A more practical question, you talk about medical vacancies and staff shortages with the transfer of services, that again is going to be a considerable problem, I assume. And if I can move on to, sorry, I nearly said it, Ed, Adam's area, excuse me. At page 48 at 2.3, I'll use a direct quote. Down here I've written, this says it all, nobody else wanted the contract, which is basically what it says, which right. The ICB confirmed to Medway's HASC and KMMH was the only provider with a necessary clinical footprint. And later on it says, the ICB has received no inquiry or representation from any other party or provider. So with NELF wanting to give up the contract, it may be the best fit to give it to KMMH, but without any competition or any other alternatives, it seems to have got there by chance, not by design, which is not the best place to be. And again, at 4.9, that's page 51, and I'm paraphrasing, you had great confidence in KMMH. At 4.10, you're then made aware of concerns. And then at 5.1, there's a considerable number of risks mentioned. You know, that does not fill me with confidence that within 3 points on the paper, you go from you had confidence in KMMH to then there are concerns raised. You should have been aware of those all along before you award a contract or enter into discussions. Right, thank you.
Councillor Wiley, Adam and Ed, just before I come in mine, if you want to answer some of what Councillor Wiley said, I don't want to keep saying that, Adam, you only get this luxury for a little while because you can keep saying your predecessor, okay? I just want to be clear. Some of them notes in that report are incorrect, the August part, because we weren't told that you went out to other providers or anything else. We weren't told that. And I know I had a list of people that was here. Ed, you wasn't. I think you was in the audience at that stage. You wasn't at the front. It was Mark and who was up with me? Natalie and others. I'm not saying. Let me just make it very clear. I'm not saying anything's been done illegally, right? I'm just trying to help you with this, with the question that Councillor Wiley is saying. We had a very confused meeting in August where it wasn't clear where this contract was how it was awarded, how it was done, whether it was put out for procurement, whether it was not put out for procurement, and it might help it rather than adding more detail. I don't really want to revisit that again now because I think we now know that you know, the only one you felt who could do it was KMPT or KMMH. But that wasn't that, and those that would have been here at the time remember the challenge that I had at that time. I had a very robust challenge around that. I think that's what you're talking about, Councillor Wiley, maybe about that. But it's just as a correction. Ed, do you want to come in with some of the risk stuff that Councillor Wiley's going to have told you?
Yeah, I would. Can I just say one thing about what you've just described, which is that so what the paper's describing is that the thing that governs the award of service contracts is called the provider selection regime. It doesn't necessarily require a full procurement, and provider selection and procurement under the regime are not the same thing. And this was, as you say, not procured in a sort of open competitive process. I know there is a lot of history around that before I arrived at the ICB in the system with the committee, but this is just describing the factual case about the basis for the ICB's award under a direct award process. So, if I come back to a couple of other points, I think you would expect us as the commissioner to do two things and I don't think I'd characterise them in the way you did, Councillor Whitey. Number one, if we see a quality concern, you'd expect us to have the same worry that everyone on the committee has about ensuring it's dealt with properly, because we're here to make sure the quality of care the residents of Medway get is the highest possible quality. So what the paper is saying is we're as concerned as you are about the quality issues the CQC identified, as concerned as Sheila and Jackie are, and we have, through our quality management processes, run by our senior clinicians in the ICB, have escalated the extent to which we have taken a close interest in the plan to solve those quality issues. So that's what the paper's describing. The second thing is that I think you would expect for a service move of this importance, serious services with lots of risk attached to them, quite a big change, for us to have a proper process around that move to ensure that everything that could go wrong, because things like this carry risk, is thought through, and that we have an assurance process. So the paper describes the assurance process that we've run. We promised when we came before we would be very transparent about the risk areas we identified. So the paper talks about them, and if you you know, we can talk about any of them in more detail if you'd like. We have sought from both NELFT and KMMH very specific assurances on things that we require to be in place for the transfer to happen in the right way. That includes recruitment of individual staff, that includes what we need to see in place around digital systems, for example, which have been two of the big risk areas we've talked about. We have escalated risks inside the ICB to talk about them, to escalate them, as Adam described, in senior discussions, because I think that's what you would want us to do to make sure this transfer happens in the right way.
But Ed, can I just, sorry, Councillor Wilder, can I just ask you, Ed, though, if KM, I mean, you had to take NEF because it was coming over. You know, it was, they weren't going to run it anymore. So if KMMH wasn't, because you said they were the only clinic, they were the, well, I'm using now Councillor Wiley's words, but they were the only footprint that you wanted to use. If they wouldn't have been the right footprint and you didn't go out to procurement, what would you have done? What would you have done then? Because you had nobody else. You didn't go out to procurement. You didn't go out to look for any other partner. You didn't go out to anywhere, which is the normal process for the ICB. I will give you due there. You normally do go out. You selected a partner. So what would you have done if they weren't the right fit and NEF were knocking on your door saying you've got to take the service back? What would you have done?
Well, I mean, that's an entirely hypothetical question. So the assessment we did is of the providers available in Kent and Medway and close to Kent and Medway and their likely fit to run a service of this sort. And we identified that given the objectives we had in the commissioning exercise around the interface between children's and adults' care, that, as I've described, that KMMH were a directly awardable provider.
But with all due respect, Ed, it's not hypothetical, is it? I'm asking you a question. You're getting these questions from around for both KMMH and for the ICB. You've got the questioning from all members around their mistrust, etc. And we're trying to rebuild that now, trying to move forward. I'm asking you if I'm trying to find out from you, and it's hard with Adam because you weren't here with your predecessor. I'm trying to find out for you, and it's just that transparency approach. And you're always good. You do tell us how it is, Ed. Normally, you tell me how it is anyway. Sometimes when you, but I'm asking you the question, if KMMH wasn't the right fit because they had their own issues, for example, if KMMH turned around and said to you, no, thank you, we're not ready for that, we've got enough going on our plate, would you have gone out to procurement? That's what I'm on. Would you have, or would you have said, no, we can't do this because actually we're not going out to procurement because there's no one out there that can do this service?
So can I come in? Because what would you do? So I think the reality is we are where we are. But what would you do in that situation if you actually thought there is a need for one particular provider to be directly awarded this contract, and then suddenly there's a reason why you couldn't deliver it, but the one who's currently providing it is saying we don't want to do it anymore? So what would you do? Well, first of all, legally, you have the responsibility to ensure there's continuity of care for the population. So you might do one of two things. You might try to renegotiate with the exiting one or the one you were still trying to award it to for something different. You may do that through a risk management strategy, a financial payment. There's different things you could do. But you would also then have to be working through what is your step-in provider model. So you would have to be looking to do an emergency award of that to something, if that makes sense. So that would be the natural process. And that has happened across the NHS. That's happened to me in my career. Someone has said, we're not doing it. And you're going, who the heck will do it? How do I make that work? The reason I come in there is that is part of why I've asked for the procurement and contracting review, so that we are clear in our policy, what do we normally do? And then in novel situations or things that happen differently, what do we then do going forward? And I recognise there are many questions about all the procurements that have been led and run by the ICB in recent periods. And all I'm trying to do is to say to everybody, here's how we should do that going forward. And there will be times when the ICB may decide, actually, we think this is the right procurement route for this particular service. And our commitment is to always then say the reasons why. We've discussed privately the issues regarding this award, but I think what you expect me to do, and I haven't mentioned my predecessor once, just for the avoidance of doubt for the minutes. But what I've done, I've inherited a situation. My job now is to transparently work out what's the best way to do it, and make sure that whenever we award a contract going forward, because that is our job, that we do it in good order, in good time, with good engagement, and we're clear why we're doing it. And that's kind of the approach that we will look to engender going forward.
But just answering, and you are right, Adam, let me just be very clear. You've not blamed your predecessor. I want to make that very clear. We all might do that, and we would do that under loads of decisions that have been made, and we've had 2.5, 3 years of that, which is unfortunate for all of you here, because that's why the trust isn't there. I know we're rebuilding it though, but you know, it was a question that we needed to ask, because in your review, if your review comes back like Councillor White is saying, I'm just going on your question, and when you do your review and it comes back and you says, actually, this wasn't done right, this wasn't legally it's done right, this one, but it wasn't the only option we could have gone down. It's too late then, isn't it? Too late for us then.
Well, in reality, everything that's been procured in the history of the last 10 years across so 8 legacy CCGs who all were legally empowered to do it differently, who were then brought together for 3 years, who have then now got to work that through. There are legacy things that I have inherited, and therefore the best way to approach them all is to be really clear why we're going to take an approach. So that's why getting the policy right, we'll look at all of them, and there'll be many things that people might actually really love, and you might go, you wouldn't do it that way these days, would you? But I have to also sort of be really clear. 2022, the procurement rule shifted. It introduced the provider selection regime that wasn't there before. So therefore, we have had in that period different views about creating a market, not creating a market. And I think our job now is to look at in 2026, what is the right procurement approach we should therefore take, and be really transparent about that.
Councillor Wildy, anything else you want to add, or is there any questions, any answers you're waiting for from KMMH there or not? Or is there anything KMMH wanted to add on Councillor Wildy's questions? Jackie?
Yeah, I'm more than happy, and then Jackie might want to come in. So I note your points, and you talk about the language that Jackie and I used, but I just wanted to kind of stress. So I've been the chief exec of KMMH for just over 2 years. In that whole time, so when I talk about being fragmented pathways, it's what I saw when I took on the role of CEO, looked at it and thought, we've got many fragmented pathways here, and we need to do some fundamental service redesign, which is the work we've been doing on what I described around kind of the improvements we've made. And, you know, we're proud of kind of going from the worst to the best. That doesn't mean we're proud of what we were doing before, but that demonstrates that we can deliver change. And, you know, as we said, it's about us sustaining that change going forward. I just wanted to pick up as well in terms of your comment about the medical vacancies and what we're going to be inheriting from the children's service. So we've had real success. So our chief medical officer has led this for us in recruiting to many of our inpatient vacancies in the adult services over the last kind of 2.5 years. So actually, yes, there is a national shortage, which we know, of children's doctors, sadly, but what we're doing already and have been doing as part of the work, this due diligence of kind of the current services, is thinking about what could we do differently. So how can we approach you know, recruitment to doctors within the children's services? Is there a different model we could be doing? Because we need to recognise we might not be able to recruit to all of them vacancies, but there are other posts that you can recruit to support that service going forward. So I just wanted to kind of provide some assurance. We're looking at that, but we have had some success in our own organisation at recruiting to medics, you know, and we're learning from that in terms of what we can do with the children's services going forward.
Thank you, Sheila. Okay, Councillor Wiley, all good?
Right, yes, there is to the committee, not to those, all of you has not been, yes, guests, yes, good word. I do think, and I'd like to recommend that this is sent to our children's and young people's ONS, because it's very important and it does affect children. And I know we have the cross-committee responsibility to look at it, but I do think Children's Committee should hear and understand what's going on.
I think you're right. I think we've answered that. We've answered that yesterday. Councillor Joy put a request through. We have answered it quite thoroughly. I think we do notice that all age one sits with us. And what I've always done, and you know this, what I've always done whenever it's an important element, and guests know this as well, I've invited the chair and the vice chair and the opposition spokes of children's to this, because I think it's something we should all hear. I think you are right, though. Other stuff around areas of the delivery where it's children-based focus should definitely be at children. So we will take it on board. I do agree with that. Look, I know you've been here now. I just want to finish with a couple of my bits then, because it's a long time. We have been firing at you for a long time. I think the only thing from me is, look, I've got to agree with Councillor Perfect. I know, Adrian, you know, I took part in that consultation of your rebrand. I didn't realise you was going to go from 4 letters to 4 letters again, you know, and I don't want your director of communication going mad, because I know the amount of work they put into these brand exercises is a big piece of work, and I get it. It's not just a headed note paper. However, I think we really do need to open up the relationship with KMMH here in Medway. We haven't had a good, we have had a good relationship with officers. I know when our last meeting hit the press, I know Councillor Perfect, and I certainly got tons of emails, not just from Medway, but across Kent, about they can't access service. And I didn't answer them. I did say that to you. We've had that conversation, Sheila, because it was all about and even for some clinicians down East Kent Way as well, which I didn't answer because we're Medway. And it's not that I don't want to answer them. It's probably where I did say I'd pass it on to you for questions or for you to answer. But I can tell you honestly, from what you've heard today, I think you've got and I have to say it again, your staff, I know from mental health, I've nursed, I know it's a massive task, and I know and I've said it, and I said it to Donna, and I said it to Adrian last time, your staff are your amazing asset, right? And you've heard me just say it to the hospital, it's down to the governance and leadership to make sure we don't let them staff down. But this committee, and I think our Medway residents, well, from the assurance from this committee, we don't know exactly what you're doing here. And I feel we need to open that door a bit more. We need to be learning more about KMMH. And Adrian, you know, I've said about development sessions offline. We have development sessions with the ICB. It doesn't have to be in this committee, but I think the more we learn about the services you deliver and the challenges you deliver offline as well as on, it helps this process, because then I don't want, you know, because I think I'm going to be fair to say KMPT, and Councillor Wadi would agree, I think KMPT's always been almost like an MF5. It's like you'll be under closed doors and we don't see you only when something goes wrong. And that shouldn't be how we do this relationship going forward. It should be better than that. And I think Adam and from the ICB, I think we've learned, we're learning our lessons from before and hopefully rebuilding that trust, hopefully. But, you know, you are going to be coming back because we have got an SV, so there will be that open questioning we will be doing, especially around the services. And obviously coming back and telling us how you're getting on with with making your service safe. That's the #1 priority, isn't it, for all of our patients coming through your door. But we do need to open. Now, I know members have given me a comment about wanting me to do a formal letter of concern to Adam. around, I think it's about noting that formal letter of concern from the Scrutiny Committee. It's not just the SV, it's noting our concerns and our worries. I think that's nothing to be over scared of, but it is the committee noting their concerns. I think that's right. Am I right in saying that from committee benefit? It is an open letter, and I know, Adam, we do talk anyway, and I think there's an opportunity for you and the spokes and us to get together and have a chat as well about that. But go on, Councillor.
I'm just asking with that whether it will be possible to have those kind of data that we can look at in terms of those suggestions around, spoke about when different improvements would be seen.
Yeah, 100%.
Just an overarching set of metrics that we can have the reassurances and also that accountability in place. Thank you.
100%. And I think, Adrian, when you attend, you come to pre-agenda, and I think if you always keep that in your mind, not just the lows, but actually how you're going to take the service on. But it's not only this service, is it? It's about everything you do. It's not just about your service. But my only, unusually, because I'm normally shouting by this stage, I think, can you just open your door? I think that's my honest opinion. And it's to open your door and just let us in a little bit and let us know about your services. So I've said time and time again, that everyone around this table is our ambassadors with our residents that are using your service. And if we can't give them the information or give them the detail or the reassurance, then that's not helping you or us, is it? So if you can, but I do thank you for your time. I do thank you for giving us now your time. There is a lot of work to be done, but let's start those conversations even offline. It would be helpful for us going forward.
Absolutely.
Thank you very much. Vice Chair.
This committee would like to formally note its concerns about the process of transfer of the all-age mental health services to KMMH. As part of the SV, metrics are to be reported back to the committee outlining the milestones and improvements as discussed at committee tonight. I move that the committee notes the submission from the Kent and Medway Mental Health NHS Trust as set out at Appendix 1 to the report, and the submission from the Integrated Care Board as set out at Appendix 2 to the report. Did I miss anything?
Thank you, Vice Chair. Can we just add that what I've just said, we are going to do a formal letter of concern. I think Terry's done that. Yeah. And also, Ed, from your end, can you just give us, not straight away, but can you give us that onboarding schedule so we know it's all in order, in plan? You only got 10 weeks. How it's all going to mobilise, and is it all going to be, are we going to be really happy? Is it all going to go wonderfully well about the mobilisation plan? It doesn't have to be full detail, just making sure from day one that service is out there for the people that are going to be using it. That's what we need to know. So that's Councillor Wildey.
Sorry, and Dr. Crassetti, if I've got your name right, did invite us to go and have a look round, or so do we want that I think
we've already got that down.
Okay.
Opposition spokesman could be going to be meeting Sheila first, and we said we'd have a round table away from here, maybe come to one of the premises, and that's fine. If I was you, Jackie, I'd make sure you're out before you invite some members over. But yeah, but more than welcome for us to be. Thank you very much. Is that seconded? And agreed? Agreed. Thank you so much for your time. Thank you. Members, 2-minute break. 2-minute break. Welcome back, members. Welcome back to the meeting, and thank you. Welcome back, Councillor Hamadishi. I understand there's a tomahawk steak sitting at home for you, so hopefully it won't keep you too long this evening. And there's traitors on that some of us want to get back to as well. So I'm asking members to be very brief in the next items if we can. Let's go to the next item. Who's doing that? Is that you, Jackie? Over to you, Jackie. Just taking as read, please.
Yeah. So obviously take the report as read. Just very quickly, new strategy, it's from 2025 to 28 as opposed to what's on the front of the strategy, which is an error. So that will be corrected, but open for any questions.
Any questions, members, on item adult social care strategy? Councillor Wiley.
Right, thank you. I'll be as brief as I can. Of the 5 commitments, I believe it was the first one and the 5th one that some of the people you consulted with didn't agree with, especially the 5th one. There was it 13%? Was you there when those conversations took place, and how did they go?
Thank you. So I wasn't there. I mean, you see from the papers, there were a lot of consultations, and actually the wording has actually been amended. So the wording previously was what wasn't agreed with, and we took that on board and we've made the amendments and adapted it so that it reflects what the consultation was fed back.
Sorry, if I'm come back. The other potential authorities that we might end up joining up with this strategy as a general question, are you in conversations with other officers, other areas? And I know it might be here, it might be there, it might be across all of Kent if some people get their way. You know, have you had those conversations or?
So obviously it will only impact on Kent County Councils. The others are all are districts and boroughs and don't have adult social care. We haven't had the reach that I'd like to with our colleagues at KCC, not for the lack of trying.
And the difficult question, because I always like one, the overspend, what sort of problems might that cause if you have to make cutbacks?
So I think from the overspend is a significant challenge and something that we talk about daily, hourly, it's regular. From a cutback perspective, I would say that adult social care is currently only providing statutory services and staffing. The cutbacks that have taken place took place 5, 6 years ago. So if we were to, the only things we could ultimately do was to stop providing care, which obviously we can't do, that's illegal, or to cut staffing. And if we cut staffing, obviously that has an impact on waiting lists and so on and so forth. So it's about working more smartly, working with our providers to look at how we can provide care differently with a view to how we bring down costs.
Okay. And last one, the co-production board, who will be sitting on that more from members' point of view? Will we have some input?
So at the moment, that's only in planning stage. So we're starting with our community information groups. And then once we've built those, we'll then look at actually who's best placed to sit on the board. We're very keen that that needs to be a mixed group. So it'll be partners. We'd want Health Watch. We'd look at whether it be members on there, but actually it needs to be coming from our residents and feeding to us about actually what does that look like. So not there yet, but looking to do that later on in the year.
All right. Great, thank you. Thank you.
Thank you, Councillor Wiley. Just picking up, Jackie, on the comment around KCC. What's the blockage there?
They've got quite a shift in their management team at the moment. So they've got an interim director there. They've recently somebody's recently left. So there's just a bit of a shift, which then makes it difficult for us to get in touch with the people to have those conversations.
But not impacting the strategy.
No, and actually, some of the feedback that we've had from corporate management team is around the fact that actually it doesn't reflect LGR, so we will be making some amendments to make sure that that's captured.
You have a member, Councillor Smith.
Hi, Jackie. Thanks for the report. So it's really good to see carers kind of built into the whole strategy to sort of recognize their contributions and their needs. But you know, if you're a carer for somebody with health conditions, you've got a very unique set of needs, very unique set of circumstances. I just wondered how much intention there is to actually really address that uniqueness of their situations. For example, at every stage, every contact that you have with families, to be able to immediately identify that they're carers, like financial support, emotional support, social support, all of that kind of stuff. So I was in conversation recently with somebody from Medway Food Bank, and I know they've joined up with Carers First, and they've done some work around poverty and deprivation that affects carers because of obviously their situation. And I know they were in conversation with councillors and cabinet members about this. And I think what they are advocating for is like a carers charter, to have like an adopted policy about what support carers will get, and that at every stage there's recognition and targeted support for them. So just wanted to know what your thoughts are that and how that kind of fits in with the strategy.
So, I mean, the strategy is across the board. We have a statutory duty to support carers as well as the people that they care for. And I mentioned earlier on about the piece of work that we're doing about what does the carers offer in Medway look like. And that's not just around, you know, us doing our carers assessments, but actually what's available and what's out there. One of the things that we're looking at the moment is, would it be better for Carers First to actually do the carers assessments? There's a bit of an R in there, because actually if a social worker goes out to see somebody or a social care officer goes out to see someone, what we should be looking at is that holistically. So we need to find and make sure that if we do that, whether we do that correctly. We do well on that in some ways, not so much in others. So it's a piece of work that we need to do to make sure that we are offering an assessment to the carer. They're not obliged to take that, but it is something that we should do and we should be doing. Whether there's a carers charter, something I'm going to take away and have a bit of a think about.
Thank you, Councillor Campbell. Councillor Hamadisha, we will let you come in because you've
Thank
been
you very-
outside.
No, thank you very much. Thank you very much. I do welcome this report, this strategy. It's much needed. It provides a lot of clarity. I was just thinking around the aspirational side of such a document in terms of setting out a vision. And this follows on from a conversation I had with Councillor Cook in terms of the experience people have both in terms of health and social care. And one thing that rings true is there's an expression that people use called first date syndrome, where everything feels like a first date, meaning you have to go to tell a professional who you are, what trauma you've gone through, and what worked, what didn't work. Then an hour later, 2 hours later, a different organization asks you the same thing. And as we're talking about neighborhoods and the wider health determinants, could we think about maybe including some sort of aspiration that you shouldn't have to repeat your problems as you navigate through such a complex array of services? Thank you.
So if I just come back, so we haven't gone into it in detail, but actually the report mentions about aligning with the neighbourhood, the 10-year plan. And we're very much part of the neighbourhood health model. So I'm on the programme board. We're looking at actually how do we make sure that when we're talking about that neighbourhood team and the team around the person, that social care is part of that, but also care providers as well. So the objective would then be that it may not be the adult social care, it could be somebody from community health that's collating that information, so that again, that they're not then have to do that several times.
I mean, I think it's a really important point that Councillor Hamadisha has made, because it was always in our ethos that you should only have to tell the story once. It doesn't seem to have happened, does it? It seems that people still go from one agency to the next and have to keep telling that story time and time again.
Yeah, it's part of the challenge we have, if I'm honest, is the information, and this typical bureaucracy. No, the information that we have to collect is very different to what our health partners collect. So Care Act eligibility is very clear about the specifics that we ask people. So that's why we need to think about how do we manage that, because an OT for Medway Community Healthcare will be asking very different questions to a social worker. So it's finding that balance, because regardless whether it's neighbourhood health or how we do that, our statutory returns are very different to our health partners'
I think the
returns, which
questions are,
needs a balance.
yeah, I think the question's one thing, it's just making sure that the professionals have the background information, so they don't have to talk about that again. David, do you want to come in?
Yeah, yes, excuse me. So there was a meeting of the Neighbourhood Health Board today, immediately before this meeting, and we talked about some of the key enablers that we require to make it work well, and very specifically about that issue of people not having to tell their story again and again and again to different professionals. So this will be based around further developing the Kenton Medway care record to ensure that all the appropriate professionals have the information that they need on an individual, because neighbourhood health won't be able to work without that, because it would be, for it to work, people who are working out in the neighbourhood teams need to have access to the information to be able to deal with that individual, and people further up in the system or in other parts of the system need to be assured that people in the teams have the information that they need. Otherwise, they'll be double checking everything.
Just a very quick comeback. No, thank you for that. That's very reassuring. It's just from experience, people tend to frame what they're experiencing through different lenses. For instance, some people say they have a problem and they're happy to sit with it being framed as a problem. Some people say, no, I don't have a problem, I have a need. I have a need. You know, some people say it's a challenge. But as different services also are trying to ascertain different things or extrapolate different information before they can do something, I think this is important that we work with the individual, put the individual at the center, how they frame it. We should be able to provide a wraparound care, irrespective of care setting, from social care, inpatient wards. I don't see that really being a major problem when we've got all the advancements in technology to enable us to work around that type of framing.
Just quickly, Jackie.
So I think one of the things that is very different between health and social care is the fact that we focus on strengths. It's around what the strengths of the people are, and often our health colleagues will say to us, we need to do that shift. We focus on what's wrong with people. We look at actually what's working well for you, and then the things that aren't, how do we make that better? So that's where that culture change is going to need to be really resolved.
Thank you very much. Vice Chair.
I move that the committee notes the report and recommends the adult social care strategy as set out at Appendix A to the report to Cabinet for approval.
Is that agreed? Is that seconded? Agreed, members? Thank you. Item 7, Jackie, are we taking this report as read? Laura, we're taking the report as read. Do you want to add anything just briefly?
No, nothing to add. The data that's in the report is the latest data that's available, so happy to take questions.
Thank you, Laura. Members? You've got a content bunch this evening, Laura, unusually. No questions. Okay. Vice Chair.
I move that the committee notes the report.
Seconded, members? Seconded. Agreed? Agreed. Okay. Okay, item 8. Jackie. AMHP. Item.
That's also me, same as before. Yep, same. The data is up to date, so take it as read and happy to take any questions.
Members? Everyone's so someone asked Laura a question. Come on. She's been sitting there enjoying the evening so much. Councillor Perfect, come on.
Thank you, Laura, and thank you for attending the committee and for both these reports. It's slightly around this, actually, just around, and Jackie, you might want to come in, it's just around, obviously, some of the challenges that I know we've been having in terms of those suffering with severe mental health conditions, and then obviously this sort of comes into the point Councillor Wildey was making earlier around some of the budget pressures, and obviously those suffering from quite severe mental health challenges and coming back in, being discharged from hospital or leaving that setting and then coming back into the responsibility of the council. I'm just interested, obviously, some of this is talking around the statutory role that we've got and the role of the police. I'm just interested in terms of what some of those challenges are and some of the implications that they're having, I guess, on the overall sort of adult social care and revenue position.
I'll come in on this. So I think, I mean, so from the AMP's perspective, obviously their responsibility and role is looking at making sure that somebody that's in an acute mental health crisis, about whether they need to be detained or actually whether they can be supported in the community. And sometimes those people will be known to us and they'll already be receiving some form of care and support, and other times that they won't be, and actually that then leads on to us, doing a care assessment and having to provide that care and support. With regard to mental health, in its entirety and the number of people we support, the strategy paper talked about the increase in costs specifically around people with mental health, and we are definitely seeing that from more from a complexity point of view. There are also some challenges around funding and how that funding is split between the ICB and local authorities, with considerable pushback from our colleagues in the ICB about what is appropriate and what isn't. And so lots of conversations and meetings and discussions about how we can resolve that. There's also been a recent ombudsman finding about people who are being supported under Section 117 aftercare, about whether they should pay for their own accommodation or whether that should be met by the local authority. In the usual circumstances, we would apply for benefits for that person's accommodation, but we've been recently told that that is not the law, and that the council need to pay for their accommodation, as in being adult social care. So it's another pressure that we're seeing. So not a great place to be, but we are working with partners. And just to give a good news story, because I'd like to finish on a good news story, I was just talking to Donna Hayward Sussex then around mental health hospital discharges. We've been working really closely with our housing team, and who've found a 4-bedroom property for us. Which means that when people are coming out for a mental health ward, rather than waiting, they can actually move into that property, and we put care in around those people so that we can do some enablement. And if that works and is successful, then we'll be looking for a second property as well. So that will help bring down the cost too.
Councillor Amadushi?
Thank you. And very quickly, what sort of effects will the changes to the Mental Health Act make to this report?
Some positive changes, I'm hoping, with the tightening of the criteria around detention and the shortening of how long somebody can be detained on a Section 3, and also addressing some of the inequalities for autistic people and individuals with learning disabilities. So for us as Medway, we're in the early kind of understanding that legislation. The webinars around how that impacts us as an authority are only just now starting to take place throughout February and March, and we've got some planning meetings in following those with principal social worker and mental health leads within our organisation to look at what is that going to look like for us in terms of policy, process and kind of practice, really. So I think for us it's too early to say how it will change because it's a sort of developing landscape, but we can certainly come back when that's rolled out with an update if members would like. It is.
Just my...
Yes, certainly. If you can do so, that would be so good, because it's such a major shift and change. It might affect your staffing and the perception of trying to recruit people into that position.
If we can add that on to an action, that'd be good to come back and just update. That'd be great. Thank you, Laura. Nothing else from members. Vice Chair, please.
We're going to get that back to the committee, did we say? Yeah, sorry. Just moment of inattention there, and that's when something happened. The committee will need a report back about the impact of the Mental Health Act on the team, on the AMHP provision. I move that the committee notes the report. Thank you.
Is that seconded, members? And agreed? Agreed. Can I just say to Jackie, I know we've had some important health stuff tonight, but before I quickly go on to the work programme, I think they're really good papers. And I've said in every single meeting, we all have, haven't we? We don't give enough time to social care. And we feel like we've rushed it again, but it's because the detail is good. And because you're not, normally we should really focus on the internal services as well, because members do come to you with issues. But I just want to say, because of the quality of the paper, that's you answered the question. So I don't want you to think you just sat here for nothing, Laura. You certainly didn't. So these members would ask you questions if they really needed to, honestly. Trust me. But thank you so much for all your time on that. And Jackie, thank you for you and your team on that. No pressure, Terry. Work programme. 1 minute, starting now.
Thank you, Chair. I have got two very short updates, unusually for me. You'll notice in the report I talked under the committee development about a kind of like a marketplace member development event around assistive technology within adult social care. I have now got a potential date of the 4th of February. I will be emailing you out tomorrow to check availability, so if you could please respond ASAP, that would be super helpful to me so that I know whether we are running with that date. I appreciate it's only about 3 weeks away, but it is quite a quiet week from a committee point of view, so hopefully you can make that. And then completely by accident, I found out tonight speaking to David that you're also going to be invited to something during the day on the very same day on the 4th of February about neighbourhood health, and I hope to be able to email you some more details about that tomorrow as well. So the 4th of February could be quite a busy day for you guys if you're available, sorry.
Just a comment from me, and just one for you to take back, David, as well, is we've got to always be aware, and I know you are, David, but there's a lot of members that work, they can't always attend these, where they really want to attend, like on Neighbourhood Health, a lot of members might want to attend, but a lot of members will be working, and it's difficult for them. And I think we need to look at how we back that up somehow, how we can brief them somehow, the ones that can't attend. And what Jackie, what Terry was going to say, we've opened it up, good for the comments that have been made earlier, Councillor Wardy and yourself, around the assistive technology. We're looking at, it's a marketplace that evening, so we're looking at inviting all members to come to that rather than just HASC host it, but all members.
Yeah, so Kindy are coming, as well as some other, hopefully some other partners as well, and they'll be coming with actual technology that they use that. So it'll be kind of, you know, it'll be really good for you guys to be able to see exactly what that technology and what the equipment is that they use with our.
Terry, is that everything?
Yep,
okay, no questions. Oh, David, was you going to add something on what I said about the timers or not? Did you put your hand up or not?
Oh, just to say that the February the 4th event is an ICB event and it's a public consultation, and we were just letting HASC know about it.
Vice Chair.
I move that the committee notes that report and agrees the work programme as set out at Appendix 1 to the report, subject to accepting the proposed changes outlined in italic text on Appendix 1. No changes.
Thank you very much, Vice Chair. Is that seconded? Seconded. Agreed? Agreed. Thank you for all your work this evening, members. Good night. Have a good evening.